conduction defects, ventricular tachycardia and fibrillation. Clinical manifestation during these periods is angina, dyspnea, diaphoresis, sweating, nausea, sympathetic activation. So ultimately, skipping the more theoretical part of it, there starts reversible injury, that is the window period, in which if the revascularization is re-established, these changes can be reverted, whereas if it is beyond 20 to 30 minutes, now irreversible changes in the form of mitochondrial swelling, sarcolemmal disruption, myocyte necrosis, this usually starts after 20 to 30 minutes. Within hours to days, there is necrosis, macrophage mediated phagocytosis, granulation tissue formation, and within weeks, now the scar tissue starts forming, that is fibroblast proliferation, angiogenesis, and ultimately the myocardium now starts turning into a fibrous tissue or scar. Over months to years, there are structural changes in the form of scars, dilatation, thinning of the ventricle, aneurysm, functional changes like LV dysfunction, diastolic dysfunction, neurohormonal activation, that is renin, angiotensin, aldosterone system activation, increase in inflammatory cytokines. Ultimately, the end product is progressive ventricular remodeling. So, to prevent all of this, so these are the sequelae, that is chronic stable angina, heart failure, ventricular arrhythmias from scar tissue, functional mitral regurgitation that occurs due to annular dilatation, ventricular aneurysm, left ventricular thrombus, systemic embolization, and sometimes sudden cardiac death. So to prevent all of this, these were the sequences of events that take place on onset of ischemia right up to few years. So the earlier you catch the patient, the earlier it is better for the patient. Hence the need for early revascularization, either in the form of early mobilization for thrombolysis followed by angiography, and wherever angioplasty is possible, there angioplasty, and if it is a complex lesion, there bypass surgery. So basically, what is coronary artery bypass grafting? So it has 2 to 3 components in it. First is obstruction of one or more epicardial coronaries, creating an alternate route around the deceased coronary segment. The conduits usually used are left internal mammary, right internal mammary, radial artery, and saphenous vein. And the ultimate goal is to restore myocardial perfusion distal to the lesion, relieve ischemia and angina, and improve survival in patients and reduce major adverse cardiac effects. So how did CABG evolution take place? In the initial days, right up to 1896, it was considered that heart is an inoperable organ. Till then, even great surgeons like Billroth used to say that the one who will operate on the heart will be considered as going against his own surgeon community. So in 1896, first time Ludwig Renz successfully repaired a stab wound on the heart, and this proved that direct cardiac surgery was possible and the patient could come out of this. Before this, the heart was untouchable surgically. In 1902, Alexis Carrel developed a reliable vascular suturing and anastomosis technique. Now this had to be leak proof, waterproof, so there has to be no leak from the anastomosis. So he developed this technique, and this became the technical foundation of future coronary anastomosis. He is also considered as the father of transplant surgery, because from there we understood how to go ahead with the anastomosis required during transplant. So he performed experimental coronary bypass work in animals in 1912, and thus ultimately leading to what today's CABG looks like. But the limitations at that time was there was no heart-lung machine, there was no coronary angiography. These patients used to have chest pain and they used to be opened on table directly to see, as previously they used to do for exploratory laparotomy. Sometimes just guarding is there, they used to open and see whether there is any perforation or not. Similarly, at that time, the chest used to be open whether or not the block is there and accordingly managed. And there was no myocardial protection. By 1912, he received Nobel Prize for this vascular suturing technique. So this we are talking about everything before coronary angiography. by 1935, Claude Beck attempted indirect myocardial revascularization, and during that time what he did was he used to irritate the heart and the pericardium. Thus the two used to get inflamed, and there used to be vascularization that used to be formed in between. So this is not true CABG, but this is how slowly vascularization of the heart started to be a thought process. Then came in 1945 Arthur Weinberg, who did something called as a Weinberg procedure. Today what we do is we take the various conduits and connect them to the coronaries so that the blood can flow. But Weinberg at that time thought that if there is a infarcted area, he used to anastomose the vein directly to the myocardium. He used to not anastomose it to the vessel, he used to anastomose it to the myocardium, thinking that the channels might open up and this will cause perfusion. Then by 1950, coronary artery disease became increasingly recognized as a major surgical problem, and surgeons began exploring direct and indirect. So now research began on this. By 1953, John Gibbon successfully had used the heart-lung machine, and coronary bypass was made, came directly into open heart surgery. This allowed safer coronary surgery on a still heart. By 1954, Murray and colleagues explored internal mammary artery, which is now used for main myocardial blood supply. By 1955, Sidney Smith first was the person who harvested GSV, saphenous vein, and used it as a aortocoronary conduit. Bailey was first successful person who did coronary endarterectomy. Now this is a plaque which is formed inside the coronary. Because still conduits were into research, so whatever occlusion was there, what they used to do is they used to directly open the coronary and remove this plaque, again reclose the coronary using either direct method, or they used to take a small saphenous vein graft and just anastomose it over it. And so still as yet the CABG was not developed. Now in 1958, Mason Sones accidentally performed the first selective coronary angiography, and this was a turning point. For the first time, surgeons could accurately see coronary stenosis and accordingly plan surgery. Then in 1962, David Sabiston performed the saphenous vein bypass from ascending aorta to right coronary. Although the patient died of post-operative stroke, but technically this showed that aortocoronary bypass with vein was possible. Now this was the actual first CABG which took place. In 1964, Kolesov in Leningrad performed the first successful internal mammary artery to LAD bypass. This was done on the beating heart, and it was the first successful direct coronary bypass. In 67, vein graft was used first time by Favellaro, and this patient survived. So now slowly the conduit started developing with time. In 1968, the results were published, and now CABG started becoming more widespread, and for the first time in 68, coronary angiography plus bypass surgery became a combined diagnostic treatment pathway. So I'll just skip a few slides here because it is going to be more of history. Remained dominant for complex multivessel disease after that. After that, for as Sir said, syntax score is there. This is a scoring system in which we assess the complexity of anatomy of the coronaries and the location of the lesion. and in which up till the high risk syntax score more than 33, till there we used to consider that it is it will come up till there, the cardiologist will take care of it, and beyond that the surgeon will take care. But now with recent advances in rota and multi-vessel stenting, this picture has still now changed. So by 1985, this is one more milestone, because till now the left internal mammary and saphenous vein were considered as gold standard till now, but now they started considering over 10-year survival. The patency rates were checked, and it was found that saphenous vein had lesser patency as compared to arterial grafts. So now they started exploring into the right internal mammary also and radial artery also. And radial artery is one of the risks that was associated with radial artery was that the radial artery was prone to spasm, because the medial layer that is there of any blood vessel, that was more thick in radial artery, so it was more prone to spasm. So these patients had to be managed with better anti-spasm strategies. So by 1996, there came a newer strategy that they started using skeletonized internal mammary artery. In this, what happened, the advantage was that there was longer conduit length, better sternal blood supply was preserved, because if the main supply of the sternum is by both the internal mammary arteries, if you use them for bypass, what remains is nothing for the sternum. So what they started doing is they started preserving the smaller, they started skeletonizing, that is the periadventitial tissue that is there. They used to dissect the coronaries between them so that the blood supply to the sternum remains, and there is less post-operative sternal wound complications. So why surgeons looked for alternative of MICS? It is that there were some problems with sternotomy. First is sternal wound infection, post-operative pain, delayed recovery. There were increased number of blood transfusions. Patient had longer hospital stay, and nowadays most important factor is cosmetic concern. So they came up with what is known as minimally invasive surgery. In 94-95, mid-cap started. So what previously we used to do is sternotomy by midline, and now they go via left thoracotomy incision. So that is not seen in the midline, with minimal pain post-operative, less hospital stay. So all these factors were there. Around 6 to 8 centimeter left anterior thoracotomy incision. It is usually done off pump. Internal mammary could be harvested from the same space as the internal mammary was formed. So it was done in the same space. And but this was mainly useful for single graft, Lima to LAD. Then came the multi-port access CABG. So in this, a thoracoscope is used. The internal mammary, multiple ports, just like laparoscopy. This multiple ports are created, and from there the internal mammary is harvested, and grafting is done. If in such cases you require to go on pump, then femoral cannulation was done. What is on pump? We use cardiopulmonary bypass in case of patients where we require the heart to be arrested, or if the patient is clinically or vitally unstable during the surgery, then we take the patient on what is known as a heart-lung machine. There the heart is given rest, the circulation is taken care of by the machine till the time surgery is done. So whether by minimally invasive or by open technique, the main goal of revascularization is to relieve angina, improve survival, improve quality of life, and to prevent further ischemia and infarction. So now indications for CABG, which I think so sir will tell further. So as sir is also there. Left main coronary artery disease more than 50%, triple vessel complicated with syntax more than 33, double vessel disease with proximal LAD involvement, difficult or failed PCI or unsuitable anatomy, diabetics with multivessel disease, severe LV dysfunction with viable myocardium, and patient undergoing other who require other cardiac interventions such as wall replacement. If a patient is requiring a mitral wall or aortic wall replacement and the patient requires revascularization also, then CABG with the wall replacement is the treatment. So these are just the diagrams. I don't know whether they are visible from back. So there we see the internal mammary which is taken down, and they are being anastomosed to the coronaries. So preoperative evaluation, as such we do the routine, this is not much of importance. So surgical step in any, either may that be a minimally invasive or a midline sternotomy via midline, the access firstly is taken to the grafts. If required, patient is taken on pump. Then anastomosis proximal and distal are made. Then if the patient is taken on bypass, we wean slowly off bypass and closure is done. So this is just overview of what the heart-lung machine does. Its role is to just take care of the circulation till the time the heart is being operated on. Post-operative care is just ventilation, maintaining hemodynamics, then early ambulation, drain management, and pain control. Usual post-op medications that are required are antiplatelets, statins, beta blockers, and ACE inhibitors. Secondary prevention is, now these grafts actually are, if sir will agree with me as to what I am saying, CABG is not a curative surgery, it is just a palliative surgery. We don't cure the disease. The disease is basically the atherosclerosis that is being formed. So this is a palliative surgery. We just make the disease bearable. So the grafts that are put are from the patient's own body. They are also prone to atherosclerosis. So lifestyle modification, diet, exercise, tobacco cessation, and strict diabetes control are required lifetime so that maximum disease-free period can be achieved for the patient. The outcomes of CABG are excellent symptomatic relief, survival benefits in high-risk groups. Graft patency for arterial are considered more than 90% at 10 years. So medical adherence is equal to outcome. That is, non-adherence to the is the commonest cause of late events, that is graft stenosis. Again, further requirement of a revascularization after CABG. The key ingredient is simplify regimens and reinforce regularly. So take home message is that coronary artery bypass grafting is far more than just a technical operation. It is a combination of thorough planning and evaluation pre-op, meticulous implementation in the OT, and delicate nurturing in post-op period. It is an opportunity to restore life, hope, and time with loved ones. From the pioneering work of Kolesov and Favelarot to today's minimally invasive and robotic techniques, every advancement has been driven by a single purpose: to make coronary revascularization safer, more durable, and less traumatic for the patients and their families. As surgeons, we do not merely bypass the blocked arteries. We relieve suffering, preserve families, and give patients the chance to celebrate milestones they feared they might never see. Technology will continue to evolve, incisions will become smaller, and techniques will become more sophisticated. But the true measure of success will always remain unchanged. Every graft has to be a promise, every heartbeat restored is a life given another chance. So finally, we may operate on the heart, but what we truly save are the moments that make life worth living. Thank you.
Hello, good morning. Dr. Harshvardhan, this was very informative and elaborative topic presentation from your side. I have one insight, kindly give some insights on graft failure. Yes, because sir, some venous grafts occludes on table most of the times.
Yes, sir.
And you said just now arterial grafts patency is more than venous grafts. So yes, how we will tackle this issue, because lot of surgeons nowadays perform venous grafting along with arterial grafting,
Yes.
because most of them don't do, I think some few surgeons do lima rima Y anastomosis, and this Y anastomosis has excellent patency rate.
Right.
But venous graft is main issue from your side and R also, because
Right.
we did most of the graft angio in follow-up. Most
Right.
of the venous grafts remains occluded, and then we open native vessels, and that was difficult task for us.
Right, sir.
Okay, so some insights on this issue. How?
Yes, sir. Sir, actually the issue with venous graft is that venous system is made for it is a low pressure system ideally. Now we are using a vein that has to take the pressure of this aorta, which is to be grafted to the coronary. So basically for the arterialization of the vein to take place, it takes at least a month to month and a half for the arterialization. Secondly, the graft failure causes begin right from on table, as you said, sir, because it is the anastomosis technique, the angle of the graft, the lie of the graft, the grafting site. If the coronary has diffuse disease ahead, and if we anastomose the vein graft on a site proximal to the occlusion, the graft will not flow. Ultimately, it will keep pressurizing the venous system, and there will be endothelial hypertrophy, which will ultimately cause graft failure. Ideally, the vein graft, ideally nowadays arterial graft is considered as gold standard, sir. But there are few exceptions wherein there are no other sites from where graft or conduit can be taken. For example, if the lima while dissection gets dissected, or sometimes plaques are there inside the lima, or if the
Subclavian artery stenosis, that is the main issue.
Yes,
for
sir.
lima graft.
Yes.
Okay.
So if there is inadequate flow, there is a chance that the lima will take blood from the heart to the upper limb. So now the patient will have pain during exercise. So there are few, in such cases free lima graft can be used, sir. But if itself the lima has lesion in it, then vein graft is a must. Because the other sites that are, sir, graft sites range from gastroepiploic artery to right to cephalic veins. Radial is there. So there are multiple sites from where it can be taken. Now to address this vein graft should be considered ideally as the last graft that is being used. Gold standard even today is all arterial graft, and adequate antiplatelet localizing the site of the lesion. So these are the main points with which we can take care of. Still, sir, even in spite of all of this, the patency is going to be less than 60% at 10 years, sir. Because that conduit was not built for arterial system. It is a makeshift graft that we are using. Yes, sir.
One comment from me.
Yes, sir.
So basically what we are looking at is a total arterial revascularization wherever it is possible.
Right.
So all these patients are having complex diseases, and a surgeon is always having that challenge that if there is a disease which is complex, where to graft and
Right.
what all techniques to use. So what we believe is for the LAD, which is the mainstay, wherein the results will be far more rewarding when it comes to a stent. So slowly there are now concepts of going little hybrid, wherein you go lima for the LAD, and for the other arteries we try to give a stent.
Right.
Wherein a smaller lesions will be better tackled with a stent. So what we know is it is just a repair of a vessel. We are not repairing the entire vessel. And while CABG is giving an alternative pathway, so it is the now need of the hour is to have on a routine heart team approach. What we see in the Western population, that every angiography has to be seen and read by a couple of cardiologists, or at least a cardiologist and a surgeon, and they should come to a conclusion that a job will be best done by a surgery or a stent. Of course, in a diabetic complex disease, surgery is still the gold standard, but the technique of revascularization also matters. So going forward, if you are to use a lima rima, or you want to use a lima radial, so what are your comparisons about that kind of arterial revascularization?
Yes, sir. Sir, if you have to compare both, first is Lima with Rima and Lima with radial, considering it as a Y anastomosis. Still, as I had told in my presentation, sir, that radial artery is more spasm prone. The media of right internal mammary is relatively smaller in thickness as compared to radial artery. So radial artery is more prone to spasm, and even if the patient misses a medication, he might still have some form of angina. Usually we anastomose LAD to diagonal and Lima to diagonal and LAD, so those areas get preserved. But if the radial is now going behind to OMs and to PD or to distal RCA, then those areas will show ischemic changes on the ECG, sir. So antispasmodic medications have to go on for them.
And how is your experience with mid-cap? And if
Right,
you
sir.
have to do a mid-cap, are you preferring only the Lima, or you are going even for the other arteries from mid-cap?
No, sir. From there, I would prefer to only go ahead with Lima LAD.
So the message is, for mid-cap, ideally you should have a limited disease,
Right.
not to go for extensive
Right.
revascularization via mid-cap, because
Right.
surgeon will have a limited vision.
Right, sir. It is from a very small area, and accessing the posterior coronaries is practically difficult for in those cases. Yes, sometimes some surgeons go for bilateral thoracotomies. From right thoracotomy, they go and go ahead for right coronary anastomosis by harvesting the Rima. So there also a pedicled graft is used as for Lima, and from Rima they anastomose it to the right coronary. So these two territories can be done, but if we have to go for a minimally invasive, then the technique that is used is by going on pump via femoral artery cannulation. There we do not have to worry about the hemodynamics of or the circulation, and there we can manipulate the heart. Yes, posterior grafts are also possible, but then with the help of pump it will make much more easy.
Good.
I request all audience to, if you have any questions, please ask regarding all this. Ask.
Yes, sir. Single lung ventilation is usually preferred. Uh, yes, sir. So there are multiple criterias. It even based upon the obesity previous any thoracotomy that is done, because their adhesions are formed between lung and the chest wall. So in those conditions, it is difficult to go ahead with mid-cap.
The CABG versus multivessel stenting in survival as well as the remaining symptom free.
Yes, sir. Multiple studies are there, sir.
Which is superior, or how do they compare?
Sir, now per se the recent advances that have occurred, at this stage it is considered that only if the syntax is much more, or if the cardiologist feels that there is difficulty in revascularization straightforward by a plasty only, then nowadays bypass is considered. If, sir, ma'am.
Basically, there was a large data. First was syntax, and now in 2010 we have a global scale. And recent was recent Excel. All compared third generation stents, which are like rice, contain a superior formula. So when you compare the CABG multivessel with multiple stenting, even with the equivalent syntax score, obviously higher syntax score surgeon, we are the surgeon
Nice presentation, Dr. Saigakar sir.
Yes, sir.
Hello.
My query was same. Sir has answered that.
Yes, sir.
Whether any head-to-head trial has done in a number of times in double vessel disease or in triple vessel disease, interventional procedures are done, and in few cases CABG has also been
Yes.
done.
Sir, as sir just now told, it is the same. Actually, there is practically no difference at present now, because it is only a few conditions where CABG is now considered superior. The MESES and even I think so, sir, post-operative morbidity that is there, that has also been found out to be same in cases of plasty as well as CABG. Now both are equivalent. The only difference comes now is whether the patient wants to get a re-surgery done, a re-procedure done after a few years.
Evaluation, you have mentioned various.
Yes, sir. Right, sir. Right, sir. Yes, sir. Right, sir. Sir, for minimally invasive, we usually go ahead with pulmonary function test and pulmonary clearance. But for open cases, usually they, in whatsoever condition they are, we usually go ahead, sir.
Hello.
Hi.
Hello.
Yes, sir.
Yeah. Suppose there are two groups of patients. One is having used vein grafts,
Right,
and
sir.
other is using arterial graft, either lima or radial.
Okay, sir.
So considering that the lumen of vein is bigger and atherosclerosis chances are less in veins post-operatively, do you still support that arterial grafts are better with possibility of spasm in arteries? Or if the lumen of vein is wider and atherosclerosis chances are less, will venous grafts not be better?
No, sir. Sir, this arterialization of vein occurs in a period of 1 to 1.5 months. So even though the vein, although it is not meant for higher pressure, the changes that occur, the media starts becoming thicker within 1.5 months. But the changes that occur in the arteries are not that significant, because of which the vein starts occluding prior to the artery. And that is why the patency rates in arteries are nearly 90% at the end of 10 years, where it is only 60% patency in the vein. So
Because the changes which occur
after
to,
revascularization.
to get arterialization done.
Yes, sir.
The venous patency is just 7 to 8 years. That's why if you are putting lima, that is going to give you 25 years maximum. That's this side. But synthetic venous graft is even worse than a stent. That's why the concept of
Right.
hybrid is being said in the Bible.
Hello. I think now.
Maximum number of states one can put in a patient. There is no limit, sir, but it has to be justified by a heart limit.
Hello, sir. I think.
If say if you put a lot of stents, is it is not that there are very higher chances of stent blockage?
Obviously, sir, more metal is more restenosis. So you should always justify any procedure, as I rightly said. And you must have seen people are going for multiple interventions. Because the disease is far more aggressive. The choice of the patient also matters. If someone undergoes a PTCA at an early age, then there is a chance that he will require repeat procedures. So now, over the last 5 years, there was a debate why to do multiple stents and why are you giving a justice to that patient by putting a lot of metal. The case report of 25 stents in one patient was circulating on all WhatsApp. But see, these are all rare cases. Just to inside that debate between a cardiologist and a surgeon. But I must tell you now, the concept in all our conferences is towards less and less aggressive metal-less PCI with a lot of imaging. See, practically in Karat now we are doing OCT and IVUS, wherein we can actually look at the plaque, which he has already told us that you can see the physiology of a block, we can see the anatomy composition. People at the age of 30, they are getting calcification, calcified blockages in the heart. So now we have an option of just doing a proper cutting balloon, rotablation, shock wave. These are the methods to cut down the metal in a artery. Now there is another concept of a drug-eluting balloon. So by using that drug-eluting balloon for a diabetic small vessels, we can prolong the need of a surgery actually. So the concept is not putting more stents. Concepting is to minimizing the number of intervention. Stents are only when you cannot avoid, age-limiting dissection and all. Once a dissection occurs, you have to put a stent to prevent the artery from closing or call a surgeon. So you can do multiple balloons rather than doing multiple stents. But suppose a patient at the age of 30 gets, a diabetic 3-vessel disease, it is really a bad picture for him. So I still believe in such cases, surgeon has to be called on table the same day or maybe the next day, and the intervention can be deferred till a surgical heart team approach comes and advises him as a CABG or a stenting. Thank you, sir.
Hello.
Just a last small point which I would like to add. Sir, the question is how many stents maximum can be placed. Sir will agree to it that number of stents can be maximum, leaving only the distal part for us. If in the end, after few years, a CABG is required, that area should be spared for that anastomosis.
Hello.
Yes. Right, sir. Right.
Right. I think now we'll have to wind up this session.
Yes.
And this was a very nice, very explanatory, extensive, nice, wonderful lecture by Dr. Saigavkar sir. Thank you very much, sir.
Yes.
Now I will request our chairpersons, Dr. Prashant Pawar sir and Dr. Vijay Singh Patil sir, to felicitate Dr. Saigavkar sir by offering memento and bouquet. Hello. Hello. Now I request Dr. Ajay Brahmnalkar sir to felicitate our chairpersons. Dr. Brahmnalkar sir. Thank you, Dr. Brahmnalkar sir. Now we'll move on to our next lecture. I think this plaque story is not yet over, and as you know, the dyslipidemia is the main culprit behind the formation of plaque. So it is mandatory to discuss dyslipidemia also at this juncture. So I'll request Dr. Suhas Mole sir to come on the stage and deliver the lecture on dyslipidemia. And for this session, I'll request Dr. Ajay Bhattad sir and Dr. S.P. Joshi sir to chair the session. Dr. Bhattad sir and Dr. S.P. Joshi sir to chair the session, and Dr. Suhas Mole will be delivering this lecture. Dr. Mole, please.
I thank all the office bearers of IMA Kara to invite me here to chair this session. This lecture will be by Dr. Suhas Mule, who is a Chief Interventional Cardiologist at Manipal Sahyadri Hospital, Karad. So I request Dr. Mule to start his lecture.
Good morning all. Good morning all. I am Dr. Suhas Ramchandra Mule, currently working as a Chief International Cardiologist at Manipal Sahyadri Hospital, Karad. Today my topic is related to recent guidelines on the dyslipidemia in 2026 by ACC-AHA. So dyslipidemia, first of all, is elevated blood cholesterol level, hypertriglyceridemia, and elevated lipoprotein A. So the background for these guidelines, why dyslipidemia management matters. First of all, dyslipidemia is the most prevalent and modifiable risk factor. So currently the PCE, the pooled cohort equation, is replaced by prevent ASCVD equation. The prevent is predictable risk of cardiovascular disease events in a atherosclerotic cardiovascular disease. So that equation has age, sex, systolic blood pressure, total cholesterol, HDL cholesterol, diabetes, smoking, and EGFR as a factors. So out of them, the total cholesterol is most modifiable risk factor, where we can modify by using pharmacotherapy, lifestyle management. So early identification of dyslipidemia reduces lifelong cardiovascular risk burden. So in this 2026 guideline, risk-based patient-centered approach is there. So in the scope, what are the dyslipidemia? First thing is hypercholesterolemia, then hypertriglyceridemia, and the elevated lipoprotein A. So for primary and secondary prevention, we use pharmacotherapy to reduce the LDL cholesterol. Initially, we just know that LDL cholesterol is only matters, but right now the novel biomarkers are hypertriglyceridemia, lipoprotein A, apolipoprotein B, non-HDL cholesterol. All these things matter, including LDL cholesterol. So the key updates, the most important is the prevent ASUD risk equation, where we, as I mentioned, we use factors like age, again, sex, systolic blood pressure, total cholesterol, HDL cholesterol, diabetes, smoking, and EGFR. Rightly, EGFR is mentioned in the prevent ASUD equation. Apolipoprotein B is a risk marker in a metabolic syndrome, while now it is included as a lipoprotein A. So universally, everyone should measure their lipoprotein A at least once in their lifetime. So the targets are, for a primary prevention, the LDL cholesterol should be less than 70 milligram per deciliter, and for secondary prevention, it has to be less than 55 milligram per deciliter. So recently, novel pharmacological agents have been added, which are like inclisiran, the PCSK9 inhibitors, bempedoic acid, and ApoC3 inhibitor olezarsen for hypertriglyceridemia. So lipid screening is recommended in all the adults at the age of 19, whether it is a fasting or non-fasting. We have to measure all our lipids at the age of 19, first thing, then every 5 years after that, and for children at the age of 9 to 11, we have to screen all our children for lipid levels. So in a case of hypercholesterolemia, in a familial hypercholesterolemia, we have to use cascade lipid screening in all the family members. All these are class 1 recommendation level 1. So the key lipid parameters for diagnosis are LDL, non-HDL cholesterol, apolipoprotein B, lipoprotein A, and hypertriglyceridemia, triglycerides. So the how to ASCVD risk assessment we have to do. So what is ASCVD is atherosclerotic cardiovascular disease where there are some events happen in our life. The most important is acute coronary syndrome which is happening in a previous 12 months. If there is a history of myocardial infarct in a lifetime, excluding this ACS, then a history of ischemic stroke and the symptomatic peripheral arterial disease. These are the major events happening in anyone's life are ASCVD risk factors. And there are some high risk features like when age is equal to or more than 65 years, patient who have underwent CABG or percutaneous intervention, who have current smoking as a habit, then there is diabetes, history of heart failure, hypertension, and when the LDL cholesterol level is more than or equal to 100 milligram per deciliter. These are the high risk features. So according to that, we use this prevent equation, and with that equation we can classify patient as having low, borderline, intermediate, and high risk for atherosclerotic cardiovascular disease events in their lifetime. So with the risk threshold for statin initiation, when the risk is equal to or more than 7.5%, we have to start statin therapy. So the gold standard for dyslipidemia is statins, having the first thing. Then we have additional second line drugs like ezetimibe, and third and fourth line drugs like PCSK9 inhibitors. So the risk threshold for statin initiation is equal to or more than 7.5% intermediate risks. While personalized with risk enhancers, in someone's life risk enhancers are there like family history of premature atherosclerotic vascular disease, then patient is having chronic kidney disease where eGFR is less than 60 ml per minute per body square area, then having metabolic syndrome like central obesity, insulin resistance, having elevated fasting glucose, low HDL cholesterol, hypertension, and in that case apolipoprotein B is important, while having elevated high sensitivity C-reactive protein when it is equal to or more than 2 milligram per deciliter HSCRP, then there is a risk of inflammation. That inflammation will lead to plaque formation and the elevated lipoprotein A. So basically 125 milligram per deciliter, nanomoles per liter is the cutoff for lipoprotein A. So if we have to use measure our lipoprotein A at least once in our lifetime. So if it is less than 125, it is okay. But when it is equal to or more than 125 nanomoles per liter, then there is a 1.4-fold increased risk of having ASCVD in lifetime. When it is more than 250 nanomoles per liter, the risk increases by 2-fold. When it is more than 350, the risk increases by 4-fold. And so we should measure lipoprotein A. So another that, including all these things, if there is a coronary artery calcium score is included, when even if using statins, ezetimibe or PCSK9, if there is a risk, then we have to use coronary artery calcium score. When it is 0, we have to have statin therapy in a primary prevention. If it is 1 to 99, then we have to start statin therapy. And if it is more than 100, we have to initiate lipid lowering therapy with high coronary atherosclerotic burden that warrants statin treatment regardless of 10-year risk estimate. So lifestyle management, first is a heart healthy diet. We use Mediterranean diet or DASH diet, and where we should have a high fiber diet, and we have to avoid saturated fatty acids. then weight management, at least we have to decrease our weight 5 to 10% of the current weight, that is weight management, and we have to stop smoking, and we have to do regular exercise, at least moderate or intense. Uh, this is the diet rated, Mediterranean diet, DASH diet, high fiber diet, and reduce saturated and trans fat. We have to use monounsaturated or polyunsaturated fatty acids in our diet and avoid trans fatty acids. So the physical activity is moderate, intense aerobic activity, at least 150 minutes per week, or vigorous intensity for 75 minutes or more than that, and if needed, resistance training including muscle strengthening activities, at least 2 sessions per week. So the pharmacotherapy, first line is always statins, second line is ezetimibe. In third and fourth line we use novel agents like PCSK9 inhibitors, evolocumab or inclisiran, and novel agents other. So this is the list of all the pharmacological agents. First is the statins, then ezetimibe, then the PCSK9 inhibitors including monoclonal antibodies, then inclisiran is a small inhibitory RNA against PCSK9 inhibitor enzyme. Then the bempedoic acid is acid ATP citrate lyase inhibitor, which can decrease the hepatic cholesterol synthesis. And then comes for triglycerides, we have omega-3 fatty acids, fibrates, and the ApoC3 inhibitor olezarsen. Olezarsen is first drug included in 2026 guideline for decreasing triglyceride levels. That 50 to 70% of triglyceride levels will be decreased by olezarsen. So the first line recommendation for statin therapy is for primary prevention, then for secondary prevention, and high intensity statin prepared over moderate intensity in atherosclerotic cardiomyopathy patients. So after that we have to reassess with lipid panel 4 to 12 weeks after initiation of the therapy for the response. So if the LDL cholesterol level is equal to or more than 190 milligram per deciliter, we straight away start with statin therapy. So first thing is a high intensity statin we have to use. If that for 50% or more than 50% LDL cholesterol to be reduced, if the target is not achieved, on the second step we should add ezetimibe, that will decrease 15 to 25% of another LDL cholesterol levels, and even with that the target is 55. If LDL cholesterol is more than 55 including statin and ezetimibe, then we have to add PCSK9 inhibitor. So target is less than 55 milligram per deciliter. So first thing is a high intensity statin therapy. If then if it is still more than 55, then add ezetimibe, and if still more, then we have to add PCSK9 inhibitor. So PCSK9 inhibitors are like monoclonal antibodies like evolocumab, and there is a small inhibitory RNA like inclisiran. So either of them can be used, and again same thing, we have to assess lipid levels every 4 to 12 weeks for the response. So that is related to LDL cholesterol. Now it is a hypertriglyceridemia. The level has to be less than 150. If it is equal to or more than 150, the first level, then the lifestyle modification is required. If it is more than or equal to 500 milligram per deciliter, then we have to prescribe omega-3 fatty acids, that is eicosapentael ethyl for 4 grams a day. And if it is more than 1000 milligram per deciliter, we have to hospitalize the patient for the treatment. So severe hyperglycemia treatment for pancreatitis prevention is a class of recommendation is 1 for hospitalization. So there are some special populations where we should reduce that LDL cholesterol. Where the first thing is diabetes. When diabetes, the level is less than 70 milligram per deciliter. And for a chronic kidney disease, if it is not on dialysis, we can use statin plus with or without ezetimibe. And if it is patient is on dialysis, we have to adjust the statin dose. For HIV patients, they are having high chances of chronic inflammation along with the drugs they used. Then for them, statin, rosuvastatin and pitavastatin are preferred because of the less cytochrome P450-3A4 interactions with protease inhibitor drugs. And pregnancy, statins are straight away contraindicated. In that case, we can use bile acid sequestrants like cholestyramine. And for cancer survivors having the chemotherapy like anthracyclines and radiation therapy, the ASCVD risk is high. So we have to use statin therapy. So the clinical takeaways in 2026 guidelines are: the first thing is early lipid screening improves prevention. So for the children at the age of 9 to 11, we have to assess their lipid levels, and in adults at the age of 19, we should start screening. Then the risk-based therapy guides treatment decisions. So the risk-based therapy is depending upon the prevent equation and risk enhancers as mentioned, and the coronary artery calcium scoring. So lifestyle modification remains non-negotiable, that like smoking cessation, then the weight management, 5 to 10% of weight loss, then exercise and diet, Mediterranean or DASH diet. Then the statins are first line, and accordingly, if levels are not maintained or LDL cholesterol is not less than 55, we have to escalate systematically, adding another drugs. And novel therapies expand treatment arsenal. So the inclisiran, bempedoic acid, and olezarsen, these are the novel recent drugs included in the guidelines. Thank you.
Due to lack of times, question answer session will be taken afterwards.
So after, thank you, Dr.
US, Italy, Turkey and Singapore. He connects through his YouTube channel Ayushman Bhav, making healthcare simple, relatable and empowering for common men and as well as all doctors. Over to Dr. Neeraj.
Thank you, Rahul, for calling me today. And I'm not going to speak in front of you as a surgeon. He introduced me as a surgeon, but I'm going to share my personal life story, and I'm going to take you all through this life story. And I'm sure that these 30 minutes today would definitely bring at least one change related to health in your life. This is my photograph of 2022 March, and all my childhood I was playing badminton. I was district 4th seed, but never used to win tournament because you know 4th seed semi-final जातो हारतो आणि घरी जातो. So it was an incomplete cycle in my mind, and post COVID I thought that I should give some focus to my health, my fitness. I started working on my fitness. And March 2022, I won IMA Doctors Badminton League Singles. I won IMA Doctors Badminton League Doubles, and I was runners-up in mixed doubles. I felt at the cloud 9. And next week at a WealthCon get-together in New Mumbai, me with my 15 more doctor colleagues, we all fell from 4th floor in a lift to the basement, and I had a fracture of my lower neck. And to those who are good in orthopedics, this was a compound fracture with 3 centimeter bone deficit of my left leg. So everything shattered for me. I was shifted from New Mumbai to Pune in an ambulance and underwent an emergency surgery. The surgeon, Dr. Tapasvi sir and Dr. Lokhande, did an emergency surgery at night, but they were not able to bring satisfactory closure. It took around 6 hours. They had to take a bone graft from my left iliac crest, and fortunately the surgery got over. When I was in casualty that day in pain, I asked my treating surgeon, "Sir, I have just won my badminton tournament. I want to play badminton. Will I be able to?" And he said, yeah, definitely, in 6 weeks. Neither me, neither the surgeon both knew that it is not going to happen in 6 weeks. There was a follow-up series of chest X-ray, leg X-rays. 3 months happened. There was no healing. 6 months happened. There was delayed union, and then gradually it started playing on my mind. You know, surgeon at the age of 48 who has recently won a badminton tournament, he wants to get back to his work fast. He wants to be to the where he was. So I constantly did all which was necessary for healing of that fracture, and still the fracture refused to heal. 9 months down the line, I broke. I was in tears and I could not stop myself crying, because I was not understanding what is happening and I was not seeing end to whatever is happening. I had to go to therapist and take therapy. And he only asked me one question. "Doctor, if this patient would have come to you, what would you advise him?" I told him, maybe I'll tell him, just be patient, this will also change. At the end of 10th month, the X-ray showed signs of healing. I never went back to the therapist. And a year and a half later, with a confirmatory CT, both the plates which were required to fix the fracture were removed. Here I am standing in front of you now, after 3 years, playing badminton again. Last year, I won the badminton tournament again, and that gave me the satisfaction. So I am not sharing this story to tell you that it can happen. I'm not sharing you this story to tell you that it is with us. I'm sharing you this story for all of us to understand that as a doctors, we feel that we know everything. And we feel that we are in the complete control of the situation. But probably when we do MBBS, when we do MD, when we do super specialization, rehabilitation, exercise, nutrition, psychology are probably 5 marks short notes for us. And so these all very important aspects of our life probably also become 5 marks short notes for us. And we need such big jolt to happen to thinking ourselves that we want to change. I'm sure all of us as a doctors in our practice, whenever a patient comes to us and takes prescription from us, in his prescription, besides medicine, all of us must be writing to him, follow diet. All of us must be writing to him, follow exercise. And I am here standing in front of you asking all of you, are we all really following the diet? Are we all really doing the exercise? So it's not whether we want change or not, we will have to bring that change ourselves. You know, most of us here sitting have hospitals. And if I have to ask you which is the biggest asset in your hospital, you will tell n number of names. A surgeon who is an orthopedic surgeon will tell C-arm is probably biggest asset. Somebody who is a radiologist will say and CT or MRI is biggest asset. I humbly disagree, and I believe that the biggest asset for us is we ourselves, and we are not investing in ourselves. I came across, because when I went through all these challenges, I came across this beautiful curve. I also came across a very beautiful curve or article which states that now the life expectancy is going to go from 100 to 120. All of us who are sitting here and who are at the age of 60, please think you have another 60 years of life to live. Now the choice is ours. Do we just want to live a longer life, or you want to increase the health span in this remaining part of life? And if at all we want to increase the health span, probably the next 7 or 8 slides, only 10 slides out of this presentation will really matter to all of us, because change is a perception we all have to bring to us, and it can only happen by delayed gratification. So I started realizing that in the world of social media, non-medicos have become more influencers than doctors. And me being a son of teachers who were teaching community medicine and preventive medicine, I thought I also have this responsibility of health education. So started a YouTube channel. This is the QR code to the link of this YouTube channel, where authentic scientific discussions related to health have been done. I am happy to share that in 1 year I have crossed almost 30,000 subscribers by now. I have invited different specialists in the field and tried to decode the simplicity of this science, which includes lipid profile, which includes diet, which includes longevity science, which includes psychology also. And trust me, the only intent is to educate others, and I am really enjoying this my journey. So my question to all of you is that, are we accepting this change which is happening in our life, and are we anyway trying to contribute to the preventive and the primordial preventive health to ourselves or to our society? My biggest learning in these 5 years is that as I started going deep and deep into every subject, it started giving me realization that whatever I am trying to learn and understand is absolutely inadequate. As a doctors, we all carry an ego and we feel that we know everything. And the moment we start discussing different subjects to the experts in the field, we start realizing that whatever our knowledge and whatever we have learned these years is where those 5 marks short notes. We all have discussed, we all know that diet and exercise are the integral part of our life. But I am going to bring subtle changes to these words of diet and exercise. My change to diet is mindful diet. So what do I mean by mindful diet? In my practice observation of bariatrics, I have realized that in our diet, proteins are highly deficient. So if at all we have to be mindful about our diet, we all have to start asking this question to ourselves in every meal which comes in front of us. What is the protein? We all know the standard guidelines and the requirements of protein of 1 gram per kg per body weight, but none of our vegetarian diet fulfills that, and so it is necessary to have at least adequate protein in diet. The next most important aspect of diet which I will emphasize is the portions. We all do not look into how much quantity we are eating, and that ultimately leads to all the health issues which we are facing today or will be facing in future. And when we say mindful, we need to understand what we are eating. Is there protein in our diet? And how much quantity am I eating? And is it really necessary to have those many calories for us in long run? I have to share with that my exercise journey. You all heard my badminton story, but my badminton story started long ago. So when I won my first tournament, a couple of years before, I had decided about a resolution that I need to be healthy. And I'm happy sitting in front of a crowd where there are enough examples of exercise and fitness in front of you. So my exercise journey started with a health coach who told me, start joining gym. So as usual, like everybody, 1st of January, I joined gym. And in the next 3 months, probably I went to that gym for only 15 days. I was not enjoying gym. I was not enjoying weight training. I went back to him. You have asked me to join gym, but I'm not enjoying those lifting of weights. He said, start running. I did 21K marathon, and then I had to go back to orthopedic surgeon, asking that much gulge dukhayla lagle yanta kay karo. And then I again went back to him, and he asked me, Neeraj, what gives you happiness when you are playing sports? And then badminton came to my mind. I told him, लहानपणापासून मी badminton खेळतोय, तर म्हटलं start going to badminton. That was the day I went to the badminton court. Till today, I am playing badminton. I have gone through this journey of fracture. And then he told me a very important word which is called as your athlete identity. We all have a hidden athlete in ourselves, and we will all have to find that athlete and athlete identity in ourselves. For Rahul, probably it was running and cycling. For me, it is probably badminton. For somebody else, it can be swimming. And now I again go to gym. I do 3 days gym and 3 days badminton. But I don't get bored of gym today because my focus is getting better in strength, in perspective of badminton. So my only request to all of you is, if you are not doing exercise, that is fine. And forget about walking. Walking is an Indian national exercise which is of zero value. Try and find out what is your athlete identity. And trust me, nobody will have to ask you again to start doing that, because you will start enjoying that. Well, when it comes to health, screen is a biggest hurdle all of us are facing, including me also. I am working on getting over the screen and reducing my screen time. And the biggest story which gave me an thinking was that it gave me a simile of charging our mobile device. We all here have come here, and I'm sure everybody's mobile battery currently must be at least 90 plus. Agree? But in my podcast where I discussed sleep, my sleep specialist told me human body's charging happens by sleep. So are we really charging ourselves adequately is a question we have to ask. And the biggest hurdle for not charging ourselves is the screen. So there is a very beautiful episode on sleep hygiene. This is a new term I have understood, and that tells us how it is necessary to get rid of the screen, have adequate sleep, because when the sleep is lost, it cannot be recovered. It is same like muscle mass. It is same like health. And probably this is one of the easiest things to recover, and we are ignoring today. So please, as you put your mobile to charging, put also yourself to charge. Have adequate charging every day, so that every day which we spend will be spent to the best of our efficiency. I was asked to speak about health, but in my journey I realized that health always starts with prevention. And here is again my own story. Both my parents are diabetic, and so I never wanted to become diabetic. I am not today also. My all focus was keeping myself fit, having a strict diet, and keeping HbA1c 5.5. And that was happening. But I was only checking my sugars and A1c. When I hit 50, I realized that there is a need of doing a comprehensive health checkup. And in my comprehensive health checkup, my lipid profiles were haywire. So doing a regular health checkup is a must, which we advise for our patients, which we do not do for ourselves. And now I am on statin. And then people ask me, "Are you एवढं सगळं follow करतो काय उपयोग?" I told them there are some gifts which happen to us by genes, which are not controllable. And that's fine. What is controllable is to understand what is happening to me and working on it by taking proper preventive care and treatment so that these irregularities can be curtailed, controlled, and prevented if possible as early as possible. So my father had his first myocardial infarction at 54. 4 years down the line, I may probably get back to all of you and tell you whether these preventive measures have helped me or not. And then coming to the most important aspect, how many of us here have health insurance? Good amount of you. Now the next catch, how many of us here have adequate health insurance? So for this we will have to understand what is adequate, because as a doctors most of us feel that अरे काय सगळे आपल्या गावातले मित्रच आहेत, कोणी आपल्याला चार्ज करणार नाही. That is no longer true, because now corporates have also come and we have to pay the bills. That is fine. More than that, when a treatment is offered to us, our first question to doctors is किती खर्च येईल. If we don't want to ask this question to our doctors, the best way to have more than adequate health insurance. So this definition of more than adequate health insurance keeps on changing as per the time, and accordingly we have to adapt ourselves. So all those who have health insurance, as per the current Amscon guidelines, the minimum adequate health insurance cover is at least 20 lakhs base and a top-up, which is basically a super top-up, at least 1 CR. Those who do not understand super top-up, there are a lot of Amsconians even in Karad, you can get hold of them. So you don't need to buy a new insurance, just have a super top-up to have adequate cover. And then we will not have hesitation of choosing what is the best treatment if it, at all we fall sick. Because there are controllables and there are non-controllables. We have to focus on controllables, work around our controllables, and leave uncontrollables to our destiny. Well, I have discussed to you about diet, I have discussed to you about exercise, I have discussed to you about sleep, I have discussed to you about health insurance, I have discussed to you about mind. But what I have realized in the last 5 years is all those ideas which come to our mind as a flash are relevant only and only when we follow them to execution. And the biggest challenge we all face is discontinuity in whatever we are doing. And that is part of our life. Nobody is perfect here. Even whatever I have been doing, I have not been able to do it 100%. So for me, perfection is 80%. Even if we stop at some point of time, just start again, and that is more than enough to bring consistency. Because even if we can do it 80% of the time, trust me, it is still going to make a significant change in whatever we are trying to follow in our day-to-day life. We have to do it, and that is the biggest hurdle I see in anybody's life. But then the competition between, it's not with others, it is with our own self. And if we can do 80% of the times, that should be fine, because for others also the story is same. So this is a very famous Zen quote. It says that before enlightenment, chop wood, carry water. After enlightenment, chop wood, carry water. So I just modified this Zen proverb, and because Rahul gave me an opportunity to come in front of you and share my journey, this is my realization of Zen proverb. Before ideal health and body composition, eat correctly and exercise right. After ideal body composition and eat correctly and exercise right. Life is not going to change even if we achieve. The biggest answer which I get surprised in my day-to-day practice is वजन कमी केलेलं असतं आणि मी विचारतो मग काय झालं? नाही मग ते सोडून दिलं. अरे सोडायचं होतं तर केलं कशाला? So this is a journey of consistency from where we start can be even today. And if we start today, 80% of the time should be our goal. And I am sure all of us in our life will reach to a stage where we will be able to say that this activity of I am today has helped the biggest asset in ourselves to change and live a better life. Thank you. खूप सुंदर मोठी प्रेझेंटेशन कविता आहे पण वेळेचं शॉर्टेज असल्यामुळे ती नाही केली. Baba will take care of Karada. Wow. Any questions?
कारण आपल्याला माहिती आहे की आपण मेडिकल एज्युकेशन घेतल्यानंतर सुरुवात क्लिनिक चालू करणं ते मोठं करणं पहिला 5 जागा असते बघा हॉस्पिटल त्याच्यानंतर मोठं हॉस्पिटल त्याच्यानंतर जो चुंबक जर इच्छा झाली एखादं कॉलेज, नाही झालं तर नर्स कॉलेज, असा आपला प्रवास चालू असतो. आणि त्या प्रवासात आपण आपल्या स्वतःच्या हेल्थला पूर्णपणे विसरून जातो. आणि मला असं वाटतं की आताचे जे बरेचसे लोक उपचार देतात की सर आता 50 झाले तर काही एक्सरसाइज चालू करायचं, त्यांना आतापर्यंत काही केली नाही. तर मला असं वाटतं की 50 ही काही एज नाही आहे की तुम्ही एक्सरसाइज नाही चालू करायला पाहिजे. 60ला चालू करू शकता. त्यामुळे आजपासून जे कोणी करत नाही त्यांनी सुरुवात करा. सरांनी सांगितलं वॉकिंग म्हणजे एक्सरसाइज नाही आहे, काहीतरी ऍक्टिव्ह एक्सरसाइज होते म्हणजे आपल्या पुढच्या आयुष्याची आपण थोडी बहुत आपण स्वतःवर जबाबदारी घेऊ असं मला वाटतं. ऍक्च्युली सरांचं जे आता टॉक आहे ते छोट्याशा सेंटेन्सेसमध्ये हे करतो, समराइज करतो. आपल्याला माहित आहे की आपण सगळेच वेली आहोत, पण वेली हेल्थ फार गरजेचं असं मला वाटतं. कारण वेली हेल्थ म्हणजे काय की आपण जे काय खातो ते काही खाता आलं पाहिजे. म्हणजे थोडक्यात आपल्याला डायबिटीज, ब्लड प्रेशर असं काय आजार असले नाही पाहिजे. म्हणजे आपण जे काय असेल पुढे ते एन्जॉय करू शकतो. आपल्याकडे जे पैसे आहेत ते काही युटिलाइज करू शकतो पाहिजे. आपल्याला आवडायला आवडीला करता आलं पाहिजे की आपण तिथं पोहोचलो पाहिजे, एवढा आपण प्रत्येकाने विचार करायला पाहिजे. कारण वेल्थ हे काय नुसत्या पैशात मोजलं जात नाही, वेल्थ ही हेल्थमध्ये पण मोजलं जाते. आणि मला असं वाटतं की सरांच्या लेक्चरचा हाच एक सारांश आहे. थँक्यू व्हेरी मच डॉक्टर रायते फॉर आयसीसी.
थँक्यू सर.
Please facilitate your Dr. Raite. Now I request Dr. Dinesh Oswal kindly facilitate our chairperson. Thank you, sir. Now we will move to the next lecture, which will be delivered by Dr. Gastrointestinal Pathophysiology. His topic of today's talk is management of upper GI bleeding. For this session, I request Dr. Yogesh Nigam, our laparoscopic surgeon, and Dr. Mandeep Patel, our gastrointestinal, to chair this session.
I welcome Dr. Gastrointestinal Pathophysiology sir from Sangli. He is a certified student of gastroenterology Sangli, which is affiliated with Advanced GI Endoscopy Fellowship and the NUS National. Everybody knows Dr. Gastrointestinal Pathophysiology sir. He is a gold medalist and honored by President Dr. A.J. Abdul Kalam sir. This was the first in India for Indian gastroenterology exam in 2003. He has a Dhanmati Award by Gastrointestinal Society Mumbai. Many international and national publications. He is faculty for national and state conferences. He has finished his GI and MS, and he has special interest in interventional GI endoscopy. He has done more than 1 lakh diagnostic procedures, more than 25,000 advanced therapeutic procedures, and more than 10,000 alien and pancreatic VSC procedures. He can get a
Thank you, Yogesh, for kind words. Thank you, organizers, for giving me this opportunity. I'm very happy that a lot of my friends, a lot of my teachers bleeding is almost 80 to 150 per lakh population, and nowadays it is declining, but if you see the mortality, it's almost 2 to 10% in non-ulcer bleeding, and if you consider the varicose bleeding, total hypertension related bleeding, mortality is almost 20%. If you compare mortality with cardiac events, mortality is almost double the cardiac mortality. So I think GI bleeding that way high mortality area. And despite advanced endoscopic therapy, overall mortality has changed because they are often driven by age and poverty. Just now, Neeraj has discussed regarding the lifespan of the women. So as we are going into the more and more age, advanced age, we are not talking about poverty, co-prescriptions, not of medicines. So still the mortality is still high. As I know, a lot of people they are into general practice or they are in different specialty. So there are a few common terms what we use in practice. There is upper GI bleeding. Is bleeding arises from the upper GI tract, esophagus, stomach, and proximal duodenum. Mid-intestinal bleeding is bleeding from the small bowel, and the lower GI is arising from colon and rectum. Metastasis is vomiting of the blood. The upper blood positivity means blood not visible, but the stool examination we pick up. Melanina is black color or altered blood through the stool. Hepatocyte is fresh blood coming through the stool.
The learning object of today's talk is to assess the risk, how to resuscitate patient after bleeding, pre-endoscopy management, role of endoscopy, post-endoscopy, and prevention of re-bleed. I think few of the topics what I stress will be more useful for the general practitioners also. This is a very common scenario in practice. Not only is a specialty as a physician, as a cardiologist, but as a general practitioner. Here is a 70-year male who is diabetic, having coronary heart disease, and on ecosprin, clopidogrel, and atorvastatin, has hematemesis and melanina since morning. Has clinically pallor, he is having tachycardia, pulse is 120, he is having hypotension, giddiness, and poor absorption, nothing. So with this common history, what do you think? What is the common differential diagnosis in our practice? Going to the investigation, the hemoglobin is around 6, and he has a relatively high creatinine and urea because maybe secondary hyperperfusion injury to the kidney, and UHG is normal. So what do you think this patient is having bleeding? So when I put the scope, this was the scenario. This is the large spurter which I can see in the first part of duodenum. So this is the ulcer bleeding from the duodenum. So this is common because of lot of patients they go and consuming the ecosprin, clopidogrel, and all that thing. So what are the common causes of GI bleeding in clinical practice? In fact, almost 70% of the time, as an endoscopist, we see the acidopeptic ulcer, ulcer bleed and varicose bleed. That is the commonest cause. Esophageal, like esophagitis, gastritis, duodenitis, malarious tear, vascular causes, neoplasms, doliophyes lesion, aortic fistula, hemophilia, and hemosacchus pancreatic. But even though the last causes which I mentioned, they are not so rare, because of the good endoscope, we are picking all these things. So what is changing in the etiology of GI bleeding? We are decreasing H. pylori related ulcer and bleed because everyone is using H. pylori as sometimes without endoscopy also, but I will recommend to test and treat the patient with H. pylori. But definitely the H. pylori related ulcers are decreasing. Classical uncomplicated ulcer bleeding are decreasing. But what is increasing? Because of advanced age, lot of patients on multiple drugs, lot of patients on antiplatelet therapy directly overlapping anticoagulants, NSAIDs because of joint pain and arthritis. These patients they are increasing. The varicose bleeding because of the we have biggest epidemic of non-alcoholic steatohepatitis, which is called as metabolic associated liver disease, where we are getting patients of cirrhosis, and because of non-alcoholic liver disease, again very important. Post-endoscopic procedures are increasing, so procedure-related bleeding, malignancy, they are increasing because of increase in lifespan. The vascular lesions we are picking up very easily. So these cases they are increasing. So in total, the number of bleeding patients, they are almost static. So coming as a clinician, what history we should take in the patient and what examination we have to think. We have to see for localizing symptoms, history of prior episode of bleeding, and NSAID is aspirin or sometimes clopidogrel and osteoarthritis medicine. His past history of liver disease, vascular disease history, aortic wall repair, radiation, history of radiation, that is also important, family history of perfusion, that is also important. I will show you interesting cases. And on physical examination, most important is pulse and blood pressure. If patient is having tachycardia, definitely the patient is having significant bleed. And if patient is having orthostatic hypotension, then we have to think that patient has significant blood loss. Abdominal tenderness, skin oral examination, all these clinical findings I will show you in cases. What is the importance of physical examination in patient of GI bleeding? I will show with example. So coming to the risk assessment in patient of bleeding, the class 1 to class 4, when patient is having blood loss of less than 750 ml, means less than 15% of blood loss, there is compensation, heart rate will remain same. Urine output will be normal and patient will be normal. If the blood loss is more than 15%, up to 30%, patient will start having tachycardia, patient will become more anxious, the urine output start decreasing, and if you come to class 4, where there is blood loss more than 40% of the blood, that is more than 2 liter of blood loss, the patient will have tachycardia, 140 pulse rate, and patient will have very significant hypotension, and urine output definitely decrease, and patient have altered mentation. So, what are the things we have to take into consideration while assessing patient? Because I know there are a lot of physicians, a lot of intensivists, cardiologists, surgeons, and gastroenterologists there in the audience. So these are the very common things. A patient, this GI bleed patient of class 2, what I have described, means patient who are having more than 15% of blood loss should be hospitalized in ICU, not in the ward. And class 1 patients, even though they are having hemodynamic stability, but comorbidities, like elderly patient more than 60 years age, cardiac patient on blood thinner should be hospitalized in ICU setup. Collect blood samples, ABG and C for hypoxemia, acidosis, hemoglobin, electrolytes. RT insertion is, we have to know yes or no whether we will put Riles tube or not. At what time we have to intubate the patient, and fluid restriction. What will be the fluid of choice in patient of GI bleed, either colloid or cystoid. And most important to monitor the output. So this Riles tube is very important. I will say that if you are not sending patient immediately to the endoscopy, is most useful situation. It is for the therapeutic as well as for prognostication. Because if you will put Riles tube and if you will see the blood in the Riles tube, depending upon the color of blood, we can predict whether the patient has massive bleed or patient has less. Because if it's fresh red blood, it predicts there is a significant bleeding from the upper GI tract. If the blood color of aspirate is coffee or dark color, then may not be very active. But it is not that the negative RT aspirate patient is not bleeding. Patient is bleeding from the duodenum sometimes. Almost 1/5 of the patient RT may become negative. Coming to the blood transfusion, आपण लगेच rush करतो. Patient ला bleeding झाले, blood मागवा. But is it necessary? If patient is having significant comorbidities, patient is having tachycardia, patient is having hypotension, giddiness, then yes, on clinical examination you can ask the patient to demand for transfusion. But what should be the targeted hemoglobin? At what time you have to transfuse the blood, and what is the role of vitamin K? So most important for all practitioners is that you have to put a large bore needle as far as possible, either single large bore or you can put an IV line in both the hands. Second important thing, patient is hospitalized in ICU and having hypotension, you can put a central line, because that will be very easy to manage the complicated patient. Use crystolite. Crystolite means what? Regular lactate or normal saline. The initial fluid of choice, patient of bleeding, hypotensive patient. In your setup, whatever practice you are doing, you can start IV fluid without referring the patient. In your setup, you can start IV fluid, preferably regular lactate. If not, normal saline. If not, then you can give dextrose also, but start some fluid and send the patient. Colloids, like you can say Maxil or albumin, 5% albumin, you can use because they stay longer period, but it may not be available everywhere. If patient is hemodynamically unstable, then yes, definitely. And a patient is having comorbidities, order a blood, but I think it is mandatory or recommended to administer blood when hemoglobin is less than 7. And if you are giving the information, if you will give one transfusion of PCV, the hemoglobin rises by 1. So that is one of the important, clinically you can assess how much blood patient will require to maintain the hemoglobin around 7. And most important, it is not only hemoglobin which will give accurate idea, so hematocrit is the most important thing. And correcting coagulopathy, yes, definitely. Sometimes we use FFP when patient having multiple transfusions. There are a lot of scoring system, but I will not go into details of that. But main important is that age is more than 80, patient is hypotension on admission, if blood pressure is less than 100, if having comorbidities like cardiac failure, coronary artery disease, renal failure, these patients, they are having high mortality in bleeding. This is simple M65, means simple risk score that if albumin is less than 3, INR is more than 1.5, patient is confused, mental status is altered, BP is 90, if age is more than 65, these patients, they are having high mortality. And this is another score, we can say that if hemoglobin is more than 13, urea is normal, blood pressure is more than 100, heart rate is less than 100, then this patient we can safely treat with pharmacotherapy. So what are the pre-endoscopic? Before sending the patient to endoscopist, this is very important that nowadays proton pump inhibitor, they are very easily available. When we are suspecting non-variceal bleeding, if you are suspecting a patient of chronic liver disease or variceal bleeding, then terlipressin is the drug of choice. But you are thinking in terms of non-variceal bleed, ulcer-related bleed, you have to infuse PPI. So you will ask me what PPI is the best, omeprazole, pantoprazole, rabeprazole, esomeprazole, what you will think. So the studies has been done initially for omeprazole, but any PPI, whatever available in IV form, you have to give. If you are using omeprazole or pantoprazole, you have to use 2 vials, that is 80 milligram bolus immediately in patients of bleeding and 8 milligram per hour in drip. And the rationale for use that it suppresses acid and it facilitates the clot formation and stabilization. And you should continue it at least 3 days after the scopy also. Sucralfate is not very much useful in active bleeding, but except in post-sclerotherapy ulcers. PAUSE, I think tranexamic acid we are commonly using, but for arterial bleed it has not found to be much helpful. Again, next questions come. Sandeep and Yogesh will say that everyone calls it, do the scopy, rush the scopy. So at what time you have to send the patient for endoscopy? In variceal bleeding and non-variceal bleeding, there are guidelines. If you are thinking non-variceal bleed or variceal bleeding, first you have to stabilize the patient. You should not rush immediately patient for the scopy, but fair enough that you should stabilize the patient in first. You should not call the middle of the night, 4 o'clock, that patient is bleeding and do the scopy. First thing is you have to stabilize the patient. You can give adequate time to stabilize the patient, arrange the blood, and then you can send within the first 6 hours or first 12 hours to the patient. So in my practice, most of the time, preferably we do as early as possible when patient stabilizes. So this is very common and very clinically useful classification in patients of bleeding for diagnosis as well as treatment option and for rebleeding risk. So this is first is actively bleeding spurter, that is 1A. 1B is oozing, means vessel is still oozing. Type 2 is vessel, visible vessel but not bleeding. There is adherent clot type 2B. These are endoscopic finding, but I will show you in cases what I have encountered. Can you see, and second important, the risk of rebleeding. If you will see this actively spurter, there is 60% chance of the vessel will bleed. On the contrary, when the visible vessel is there, almost 40% of the chances that bleed. But when the ulcer is having clear base, less than 5% chance of rebleed is there. So if you will see these 3 cases, first is active spurter there. It is massively bleeding vessel. This forest 1A. So what we are doing, we are injecting adrenaline to make the vision clear. I am injecting the adrenaline first image, and once I will get the image, I will try to apply the clip. Second, same is forest 1B. It is not a spurter, but continuous oozing is there. So applying hemoclip. And type 2B, definitely, if you type 2B, yes, you can see last image. There is visible vessel at the center. So in such scenario, definitely there is a role for endotherapy. So depending upon forest classification, what we are doing, when actively bleeding, endotherapy is must. In where there is oozing and or there is visible vessel, yes, we have to do the endotherapy. But then what we cannot do all the things endoscopically, or sometimes there is chance of rebleed. So we repeat the endoscopy, and if endoscopic failure is there, then definitely surgery. Previously, I know the audience are, the surgeons are there in the audience, they used to get a lot of bleeders, lot of perforation, but nowadays, because of endoscopy, we are diagnosing ulcers early, we are treating the bleeding patients. So the indication for surgery is decreasing day by day. And because of what, it has made possible because of what? These are the hemostatic tools which are available with endoscopists. And I know, I'm sure everywhere, every corner of the city, the endoscopists are available and these things are available. Not great thing. Heater probe, then hemostatic clips. We have APC, argon plasma coagulation. We can simply use a needle and inject diluted adrenaline to arrest hemostasis. And the most commonly used is through the scope clip. Clips are easily available, and spray. This spray I will show you. This is very useful, and this doesn't require a big setup. This is a bleeder where I am applying hemoclip, and because of the endoscope, we can do the gastroscopy, colonoscopy, and we can tackle the bleeding. But whenever it is not possible to locate the bleeding, sometimes we take use of this capsule endoscopy. And when suspected small bowel bleeding, we are taking help of this double balloon enteroscope. This is like caterpillar which goes into small bowel, and we can actually treat and diagnose the diseases of the small bowel. So to show you how this argon plasma, it is non-contact method. This is GAVE, gastric antral vascular ectasia patient, secondary to portal hypertension. So we are doing this GAVE. Second, you can see the blood coming from the ampulla. This was really difficult initially to know the people from where exactly blood is coming, but because of this ERCP scope, you can see actually blood is coming from the ampulla. In that situation, we can do the embolization. This is a splenic artery which is bleeding. Second, we have a lot of other modalities also, like Apollo endosuturing device. And this last one video is showing this, the gunpowder. The American soldier used to use this powder in cases of war bleeding. So this powder now we are using endoscopically. So post endoscopically, we have to continue PPI, and most important is H. pylori eradication. H. pylori therapy is very important when suspected ulcer or ulcer bleed to prevent rebleeding of the patient. And blood thinner you can start as early as possible. I salute this great man because always the lecture becomes monotonous. Very few people like Neeraj, they will give an interesting talk. People like us will be talking on non-specific. So this is a great man who has habit of asking questions. So I will ask you some questions in my talk. It is not compulsory you should answer this, but what are the common things? See, हा कॉमन सिनारिओ आपल्या प्रॅक्टिस मधला. पेशंटला पित्त काढायची सवय असते, सकाळी उठलं की बोट घालायची, वॉक 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 उलट्या काढायच्या. So this is a patient who was having hyperacidity, presented me with a massive bout of hematemesis in the morning because of forceful diagnosis. With history you can make out what is the diagnosis. Yes, this is the bleeding malleolus tear, massive bleeding malleolus tear. Most of the time it is stops, but if it is active bleeder, vessel is open, we apply hemoclip and we can arrest the bleeding. So in spectrum of gastroesophageal reflux disorder, this is one of the complications, but sometimes these gastroesophageal reflux disorder can slowly cause blood loss and cause anemia. So in that situation, we do the manometry and 24-hour pH metry and here in the surgeons like Yogesh who are very aggressive in managing such patients with hiatus before developing the complication. Again, my second question, many of you must be aware but not knowing, who has been awarded Nobel Prize for Medicine for invention of H. pylori, because this invention of H. pylori has changed field of endoscopy. Gastroenterology साठी एक मोठं पूर्ण उत्क्रांती म्हणायचं तसंच झालं H. pylori. So these are the Barry Marshall and Robin Warren from Australia. So I always mention the story of this Barry Marshall who convinced that H. pylori bacteria causes stomach ulcer, but no one believed him that time. In 1984, since it was illegal to test the theory on human, he drank the bacteria himself. He developed ulcer within days and he treated himself with antibiotics. And you must not be aware that time only metronidazole and tetracycline and bismuth was available. He treated himself with this combination of bismuth and 2 antibiotics and he get cured of this. And he was explaining this theory throughout the world. From 1984 to 2005, he was visiting all the world, proving that his hypothesis is right. पण आपल्याकडे अजून पण लोकांच्यात समज आहे की तेलकट तळलेलं मसाल्याचं मैद्याचं काय खाल्लं की अल्सर होतो. It is cause for reflux, that precipitate reflux. But ulcer is because of H. pylori infection or NSAID consumption. And because of for his research, he got Nobel Prize in 2005. And 2008, I got opportunity to meet in one of the international forum. And it has become very easy. Any endoscopist can do the H. pylori biopsy from the antrum. This is a kit very easily available, and this is negative. First is test and second is positive. It became immediately pink because of the release of ammonia. pH indicator. And triple drug therapy, it is gold standard. The kits are available. We are at present using clarithromycin amoxicillin on any PPI for 14 days to treat the H. pylori infection. Again, this is one of the question, is a 30-year male of consanguineous product of consanguineous marriage, pigmentation around lips. I has 2 episodes of interception, melena and hematemesis. And when I did the gastroscopy, there was a polyp in the duodenum, which was intermittently bleeding. And you can find out on the mucocutaneous pigmentation what must be the differential diagnosis in this child. Diffuse jugular syndrome, yes, right. Again, very interesting, similar history. Is a 60-year lady who presented with melena and hematemesis. You can see the blood continuously she is oozing from the duodenum. She has recurrent spontaneous epistaxis since childhood. She has multiple ENT treatment for epistaxis. And on examination also, she has telangiectatic red spots on tongue and nose. And she has iron deficiency anemia. So what do you think of this? Osler-Weber syndrome, HST, hereditary hemorrhagic telangiectasia. So this can present with GI bleeding. So in my first chart, I have mentioned that these are the rare causes, but yes, we have to think of that. We are easily getting all these patients. It is it's not a single patient. I have so many patients who are frequently coming with this. Again, this is very challenging patient who presented with massive GI bleeding from Bijapur. He has done gastroscopy, colonoscopy as Bijapur, and referred to me for enteroscopy to find out the cause of bleeding. But he was so bad condition, I thought before enteroscopy I have to do the CT angio. But when I did the CT angio, there was large aortic artery aneurysm. And second CT image, you can see the aorta which is communicating to the third part of duodenum. So he has aortoenteric fistula. So aortoenteric fistula, you must be aware, very bleeds, massively they bleed. And it's a very rare cause of GI bleeding, but mortality is almost universal. Almost 90% of the patient, they bleed if you don't diagnose this patient. So what I did, I sent the patient for EVR. The CVT surgeon did the endovascular repair of this patient, aortic repair, and you can see this fistulous opening in the third part of duodenum. This part is a part of bleeding, and I have applied the clip up on the enteral side, enteric side, duodenal side. And we have in regular follow-up of this patient for after 2 follow-ups of CT angio, patient has never bled again. Again, you can see the spurter, massively bleeding the vessel at the near GE junction. Painless bleed, no NSAIDs, no chronic liver disease, but patient has bled to death, hypotension, very massive bleed. What must be the first diagnosis? Bleeding near GE junction, without chronic liver disease, without NSAID. Yes, this is gastric doliphized lesion with bleeding, a large submucosal. This is persistent caliber artery. The artery itself sometimes opens and it bleeds to death. Again, we are doing a lot of intervention. So one of the common cause nowadays we are getting is post-procedure. This is a cystogastrostomy I have done. And on day 5th patient, I discharge the patient, and 5th day patient come to me with massive GI bleeding. This is the cystogastrostomy stent, patient has bleeding. The patient was having pseudoaneurysm and patient bled from the pseudoaneurysm. In such situation, we never hesitate to take help of interventional radiologists. So it is not that I am an endoscopist, we are doing all the things. We have to take help of interventional radiologist, like surgeon. And this is a very common scenario. Patient has bleeding after ERCP, post-sphincterotomy bleed. So we can apply a gunpowder, we can say the coag, or we can inject. Again, the second part of my talk is the another common cause of GI bleeding. So here is the again common scenario everyone has faced: chronic liver disease patient, DCLD, decompensated chronic liver disease patient, alcoholic patient, consume alcohol for more than 30 years, presented with massive GI bleeding, hypovolemic shock, pulse is 140, BP is 70, hemoglobin is 4. My question to all of you that what you will do first to arrest this bleeding? Will you control bleeding using endotherapy? Will transfuse the blood? Will start injection terlipressin, octreotide, vitamin K, or metoclopramide perinom? Will start beta blocker to the patient first? What will do first? When patient comes to you, you may not be in a endoscopy suit or may not be in good endoscopy setup. So you first have to start pharmacotherapy, that is terlipressin and octreotide. You have to transfuse the patient. arrange for transfusion and then send patient for endoscopy. And this was the same patient, what I was mentioning, he was bleeding from the large fundic varices. So we don't get much time when patient is actively bleeding, we don't apply coil, but I have injected glue, and you can see same setting, while coming back, you can apply band. So glue injection and banding has become a gold standard in patients and has changed a life of patient. Again, this is one of the very easy and spot diagnosis. Here is a 25-year lady who presented with chronic liver disease with anemia, multiple transfusions. And when I examine clinically, in my second slide, I mentioned that clinical examination is very important. When I examine the patient, these are the dilated veins, dilated abdominal veins. So she has a postpartum Budd-Chiari syndrome, which is presented with bleeding. And again, this is one of the common cause of chronic liver disease in pediatric patient. I don't know Valembe sir is here or he has left. Dr. Valembe? He was there, came to me. He's very fond of that pediatric patients. So here is a patient who has a ring at the sclerocorneal junction. So it's a case of Wilson disease. I think Dr. Gargati is the only pediatrician. I don't know any other pediatrician there. But this is very important. Clinical examination is very important in each and every patient of GI bleeding. So what are the predictors of large varices? Severity of liver disease, platelet count is less, spleen is palpable. Then we have to think, and like non-variceal bleeding, we have to take consideration into drugs. First and foremost important, if you are available with terlipressin, I will mention those who are handling the ICU setup, you have to keep ready. Terlipressin has changed the all scenario of bleeding. It is wonder drug in patients of GI bleeding. Octreotide, if not available, you can use. Antibiotics in patients of GI bleed prophylactically very important. You can give ceftriaxone or norfloxacin or rifaximin, because the bleeding causes hypoperfusion and transmigration of the bacteria and precipitates complication like spontaneous bacterial peritonitis. Even chances of pre-bleeding has decreased after antibiotics use. Registration, main important thing is bleeding, that we should not over transfuse. We give lot of blood, even though patient's hemoglobin is naive, we transfuse. So don't over transfuse the patient, because excessive blood transfusion may increase the portal pressure and patient has again chances of bleeding. So don't over transfuse. Coming to the pharmacotherapy, most important, my question is to prevent beta blockers. We can use non-selective beta blockers like propranolol or mixed alpha and beta blocker like cardiolol to prevent the recurrence of bleeding. And you can titrate the dose of beta blocker. As I mentioned, endotherapy has become a gold standard in treating the patient. I think long back, 30-40 years before endoscopic era, shunt surgery, devascularization surgery were gold standard. But nowadays we have good endoscopists available everywhere, and not only a glue, but we are using nowadays coil. I will show you interesting case of coil. Here is one patient referred from Satara to me. He has a case of extrahepatic portal vein obstruction. He has bled massively, and he presented with and one surgeon from Satara did the banding of the patient, and patient came to me with post-banding bleeding. So he saw on day 5, and he came to me, you can see, he's massively bleeding from the esophageal varices. On second image, you can see the band there. Lower down band is there. So very terrific situation for endoscopist. I am injecting a glue here to arrest the bleeding, but unfortunately, I couldn't do. Patient went up into hypovolemic shock, and I have to send back patient to ICU for stabilization. So what are the things, what are the options available for endoscopists to do in such massive bleeding? We can repeat endotherapy after stabilization. Yes, that is one option. TIPS, transjugular intrahepatic portosystemic shunt. TIPS is also available, I think, most of the places. That is done by interventional radiologist. And last option is shunt surgery or devascularization surgery. But as patient is young patient, lifelong risk of TIPS, anticoagulation, all that, we tried to save the patient with help of this stent. So nowadays, these ELA stents, they are technically very easy, and they have again changed the whole scenario of patient treating the emergency patients where we cannot control the bleeding with help of endoscope. And you can see this is a very simple technique. It's like a normal stent. We have to pass a guide wire and we can deploy the stent. The stent causes the compression or gives the pressure on the esophageal varices and temporarily arrest the bleeding. And we get a time of 4 or 5 days to take a call on TIPS or any other intervention like surgery we have to do. And this is where patient has undergone DVAS and shunt surgery, and patient came to me post procedure for removal of this ELA stent. So just I meant to say that there are a lot of options available. The dictum is that if patient reaches to your hospital, reaches to endoscopist table with palpable pulse, should not die of bleeding. That is the rule. And we have the alternative measures that what I meant to clear to the audience that how the tips has been done. They do transjugular, and they put a stent with the same stent cardiac people they are using or we are using for the palliation material. So these are they are not drug eluting stent, but we from hepatic veins to the portal vein we bypass the area to reduce the porosal pressure. But again, this Sunstaken Blackmer tube in our surgery practical, we used to see a lot of table viva this question, but nowadays yes, it has limited role, but I will suggest everyone that you should have this tube in ICU setup who are having ICU, because whenever a patient is not fit for endoscopy, you can use this SB tube to prevent bleeding. And this is a large fundic variceal bleeding, yes, this is a glue, but whenever patient is not having bleeding or active bleeding, sometimes it may be difficult, but we have another options because glue has itself complication. Sometimes the glue is like Fevikwik, the cyanoacrylate, N-cyanoacrylate material, which sometimes get embolized into systemic circulation and can create a problem. So now we have a better treatment. This large fundic pharynx, which is non-bleeding, you can see on a Doppler. This is the endoscopic ultrasound upstairs. So I am using endoscopic ultrasound to obliterate this varices. So this is called as coil embolization. So we can exactly see from what point. The last video which is running, you can see these are the varices which we have located with help of endoscopic ultrasound, and now what we are doing is we are deploying the coil. We are deploying the coil into the varices, and once the coil will be deployed, then we will inject glue. So in single setting, we can obliterate total fundic varices. It is bit, you can see last years, this is all varices. On Doppler you can see there is no Doppler flow. This large varix is totally obliterated. So there are very few complications like embolization of the glue in patients of large fundic varices. So my dear friends and my colleagues, is it like scenario like that endoscopist in 2026 handling all the bleeding patients and surgeons has or surgeons has no role? It's not like that. We are complementary working with each other, and sometimes we need, like last patient of stent, ELA stent, what I have put, I have referred that patient to surgeon for shunt surgery because patient was young and not affording for tips. Tips cost 4 to 5 lakhs, and shunt surgery can be done in scheme, MPJY scheme. So the patient underwent shunt surgery and then came back to me for removal of the stent. So we are working complementary with each other. Then last 2-3 cases where I have done cystogastromy, patient had bled, we have taken help of interventional radiologists. So we are not the boss, we have to take help of interventional radiologist, surgeon to manage the patient in 2026. So my take home message for bleed means believe in endoscopy first, localize the bleeding, achieve the endoscopic hemostasis, escalate the therapy only if needed, if we have failed like interventional radiologist or surgery, and definitive control in most of the patient is possible with endoscopy. So today's massive GI bleeding is more often controlled through a GI endoscopy than in operating table. And this is proud moment for me to show that this is the last exam of DNP Gastro. I stood first in my career, and I will always remember this world that dream transports into thought, and thought results into action. So don't stop dreaming and just be a passionate, and most important thing which required in our profession is dedication and hard work. These are our teachers, means they are the god of endoscopy. He is Dr. Peter Cotton, right side, who is so passionate about the endoscopy that his car number was ERCP1, and as an endoscopist, as a gastroenterologist, we only read his books in endoscopy, and with his inspiration I was so impressed by that thing that after my doing lot of endoscopy and lot of ERCP, I am become so passionate that I have constructed my home with the theme that the stones which I am removing with ERCP will be act as the exterior of my home, and I have named my home as a dream CBD house. Thank you for patience hearing. Pardon me? Osler Weber. Yes, pharmacotherapy, you can use that. Yes, these are the lifelong diseases. So there is no fixed duration. Even thalidomide also has been tried in so many patients. But definitely once the bleeding start, endotherapy also is not only a single setting. It requires multiple sessions of endoscopy. Whenever patient bleeds, we have to do. So there is no definitive single therapy which will require in Osler-Weber syndrome. I don't think so, because eosinophilic esophagitis we diagnose by biopsy and IgE level and peripheral smear eosinophil count. And skin press test for diagnosis I think has no role at all, because biopsy gives the clear-cut diagnosis, and endoscopist, when we do the endoscopy, we typically see trachealization of the esophagus, means we multiple circumferential ring. Patient comes with either stricture or patient comes with the dysphagia, and we start them on steroid. It is not only the esophagus, sometimes whole GIT is involved. We have eosinophilic enteritis along with that. We have eosinophilic gastritis in that patients, and these patients, they respond very well to the steroid. We most of the time prefer to give them budesonide as a drug of choice, and they respond excellent. So I don't think PRINT-PREC has much role in diagnosis. Serum IgE level, yes, definitely serum. We have to monitor serum IgE level also in this patient.
Thank you, sir. More questions will be dealt during lunch because we are already running late. So now I request Dr. Kiran Gaukar, sir, who is a renowned orthopedic surgeon from our Karad, to kindly felicitate Dr. Uday Singh Patil. I request Dr. Rajesh Gargate, sir, to kindly felicitate the chair. Thank you, sir. Sir, तुम्ही पण बोला. Thank you, sir. We'll be moving to the next talk. This will be a panel discussion on management of borderline resectable pancreatic carcinoma, which will be conducted by Dr. Dheeraj Khadakban along with his team. His team includes Dr. Sandeep Patil, our DM gastroenterologist, and Dr. Shubham Pawar, who is a radiologist. I request Dr. Shantanu Kulkarni and Dr. Mote, two renowned surgeons from Karad, to kindly chair this session. I request Dr. Dheeraj sir to kindly come on stage along with his team. Along with your team, sir. By the time, okay. So I think we can start this session. I request the chair to kindly introduce Dr. Dheeraj. Dr. Shubham Pawar will be joining us within 5 minutes. He's on his way. He's a radiologist. We have Dr. Sandeep Patil, DM gastroenterologist, in his team. I request the chair to kindly introduce Dr. Dheeraj Khadakban.
Thank you. Thank you, organizing team, for inviting me to chair the session. brief introduction of Dr. Dheeraj Khadakban. He is MS General Surgery and DNB Surgical Oncology from AIMS Kochi. He is consultant surgical oncologist. He has won the best poster at regional conference. His special interest in head, neck and thoracic oncology, also in clinical research in the field of head and neck oncology. Over to Dr. Dheeraj.
Let me give a small disclaimer. We have seen all the excellent lectures since morning. So the disclaimer is I am not a very good orator, first thing. And my talk was scheduled initially at the last lecture at 4:30 p.m. But due to rain, it was preponed. So you can understand somebody who is batting at number 11 coming to bat at number 4. And third thing is, because of again rain, my team is very limited. And with that disclaimer, I might make some changes and some mistakes. So please excuse me for all these mistakes and this thing. And let me start with my talk. So I'll be talking on this borderline resectable pancreatic cancer. We initially planned for 60-minute framework, but with the time constraints, I will restrict that a little bit. I will try to do that. In 5 minutes, I'll talk a little bit about why I chose this topic and all. We'll take case 1 as a resectable pancreatic cancer, borderline resectable. Second will be locally advanced. Third is oligometastatic. There is nothing much to say, so I might skip this. Let us have some questions in 5 minutes and then closing statements over 10 minutes. So my topic, why I chose this borderline resectable pancreatic cancer, I was criticized for this actually by some few people. They're like, you should talk about breast cancer, head and neck cancer. But the thing is, these are very common cancers. We see these, in our day-to-day practice, even for physicians, surgeons. These are, routinely seen tumors, and their treatment is fairly black and white with very few gray areas in between. So I thought, let us have something which is not, very common. You don't see these tumors common, and there is a significant change. As we know, in breast cancer and head and neck cancer, most of the people know, okay, this is the treatment. You have node positive patient, little advanced tumors, you give chemo, surgery. So these are known things, but this is something which is, and because of the sheer number of these patients, the research has gone so much ahead that there are, everybody knows the treatment and everything, and the treatment is almost like, okay, this is the thing, this is the treatment. But not in case of pancreatic cancer. The treatments are evolving, and these tumors were considered deadly, say maybe 10 years back. The things are changing a little bit faster now with the new research coming up, new treatment modalities, and the chemotherapy options that we are considering right now. The things are changing quite fast. So as per NCCN guidelines, the resectability criteria for resectable tumor, there is a clear fat plane around SMA and celiac artery. Then there is SMV, PV, there is no abutment or distortion, there are no distant mets, and then surgery, upfront surgery is appropriate. But we are talking about borderline resectable. There is abutment to SMA or celiac less than 180 degree. SMV PV junction, even though it is the abutment is more, but it is reconstructable. There is no distant disease. In these patients, we prefer neoadjuvant therapy. And last is locally advanced, where there is encasement of SMA or celiac artery, and SMVPV is not constructable. There is aortic involvement or distant mets. So in such cases, we consider systemic therapy, SOS radiation. I'm coming to my first case, 58-year-old male who presented with progressive painless jaundice since 3 weeks. He is having weight loss of 6 kg over 2 months. There are no comorbidities, but performance status is good. And CA 19.9 is raised. Bilirubin is 12.4. CT showed a 3.2 centimeter mass in pancreatic head, and it's abutting the superior mesenteric vein portal vein confluence. And SMA, there is fat plane is preserved. There are no distant metastases. And on endoscopic guided FNA, there is moderately differentiated adenocarcinoma. Since there is no pathologist, I would like to skip the SMED4. Okay, so we don't have radiologists right now. I'll go to Dr. Sandeep Patil, sir. We did EUS FNA. Patient will ask, sir, this is the thing. What should I do? Whether chemo or surgery?
If it is less than 180 degrees, then probably neoadjuvant chemotherapy will work. So I think the same thing will tell the patients that if it is clear, then they can go ahead with the oncosurgeon's opinion for the surgery.
Okay. So now, since his bilirubin is 12.4, would you like to attempt stenting first, or how would you go about this?
As there is most of the patients with a pancreatic head mass with this kind of bilirubin will have obstructive jaundice with a dilated CBD. So yes, stenting first, but we'll prefer here plastic stenting over metal stenting, as we probably may plan in future about the surgery.
Yeah. Right. So is there anything that we can do instead of FNA? So sometimes the diagnostic dilemma is there. The tissue is not adequate, or so in those cases, what is your strategy for such cases?
Usually nowadays those centers who are doing endoscopic ultrasound, they prefer OSP. OSP is an on-site pathologist. Because everything is costly, including that needle. It costs around 20 to 25,000, that needle only. Patient is already intubated or under deep sedation. Once we will take the sample, and after 2 or 3 days, if the report comes tissues are inadequate, then the whole effort actually goes in vain. So OSP is actually standard of care. On-site pathologist should be there. When we'll take the sample from the needle, we'll do the smear formation, the same settings at the same site. Pathologist will confirm that the sample is adequate. The report will come later on, but at least the tissue sample should be adequate. So
we look at the adequacy of the sample.
Yeah.
Okay. So in case of say SMVPV is it's more than 180 degree abutment. So in that case, surgery is going to be a little difficult. If you ask me, it is going to be a little difficult. So in that case, would it be better if we consider chemotherapy first, or is there any other option that we have?
Neoadjuvant chemotherapy
can we consider down regulation of a tumor size can be tried, and then again reassess the lesion. If the resectability criteria met, then again go for the second look, and then decide about the palliation or again for the operation.
So in these cases, we consider neoadjuvant chemotherapy or chemoradiation. Nowadays, the evidence is increasing for neoadjuvant chemoradiation. The common chemotherapy protocols that we are now using is either FOLFIRINOX or gemcitabine and nab-paclitaxel. So in such cases, there is always a dilemma which chemotherapy to be used. In case of medical oncology, there is one trial which compared this chemoradiotherapy versus immediate surgery in resectable or borderline resectable pancreatic cancer. This is a multi-center randomized control trial, 246 patients, but overall survival was much better in case of neoadjuvant chemoradiation group with hazard ratio of 0.73 with significant difference between the two arms. But the point to note is the difference in survival is hardly 1.5 months. It's just, even though we give chemoradiation, it becomes, but if we consider this overall survival rate, in 5 years, 20% patients survive if we give chemoradiation first. As against surgery, only 6% patients survive. So in terms of pancreatic cancer, initially, say 10 years back, we were looking at, in spite of all the efforts, we were looking at 5-year survival rate of 5 to 6%. Now we have increased it to 20% with the use of neoadjuvant chemoradiation. So the conclusion for this is neoadjuvant gemcitabine. In this trial, they use gemcitabine based chemo and radiation, followed by surgery, and adjuvant chemo after surgery is better as compared to upfront surgery. So our radiologists have not yet come, so I'll take that question. After say neoadjuvant chemo or chemoradiation, there is another trial that I would like to talk about. This same trial, pre-op NAC, ANC karke, it's a trial, and it's the part 2, which compared FOLFIRINOX along with gemcitabine and nab-paclitaxel, these two chemotherapy protocols, and they were similar. So there was no difference in these two. So post FOLFIRINOX, the CA 19.9, if you had seen initially, it was 1240. It has dropped significantly to 180. But CT scan shows stable disease. There is no difference. The size is same, everything is same. So then we surgeons have a dilemma, whether shall we consider this patient for surgery or he will go for palliative treatment, considering inoperability. But in case of radiology, here we only consider the drop in CA 19.9 is more significant than what we see in radiology, because these CT findings are very poor predictor of operability post neoadjuvant chemo or chemoradiation. So CA 19.9 normalization, if it would have been less than 90, it would have been the best thing if it would have, if we could achieve after neoadjuvant chemoradiation. And there is a small role of PET-CT also, but the problem is the amount of clarity that we can get with triphasic pancreatic protocol CT. In PET-CT, it is very difficult to get that clarity. And in case of, let us say, we consider this patient for surgery after his CA 19.9 has dropped, patient is fit, his performance status is good. So SMV and portal vein confluence is already involved. We suspect that it has, it has regressed a little bit, and we can get a clear claim, but intra-op we find that it's not possible. In such cases, we have to resect the portal vein and then either anastomose or put a patch, or there are grafts also, venous graft can be considered. Okay, there is, do we have any pathologist, someone in the audience? Okay. After say we completed the treatment, resected the tumor, the pathological parameters that we see are tumor regression grade, then margins, and there is something called as lymph node ratio. I mean the number of lymph nodes which are removed divided by, I mean number of lymph nodes that are positive divided by number of lymph nodes which are removed, and that is one of the predictor which is coming up now, prognostic indicator for these tumors. Coming to second case, 52-year female, she presented with epigastric pain. She is having new onset diabetes mellitus, performance status 1, but there is no jaundice. CA 19.9 is 4,800 and HbA1c is 9.2. CT scan showed 4.1 centimeter mass in pancreatic body and neck, but here the thing is celiac axis encasement is more than 180 degrees. The celiac axis is completely encased. Superior mesenteric abutment is 90 degree. Superior mesenteric vein is occluded, and there are venous collaterals present. But there is interesting finding that there is a paraortic node which is 1.2 centimeter, and it is little suspicious. So, sir, my question to you, this is new onset diabetes mellitus, and what is your presentation, I mean your perspective on this finding?
It can be like a paraneoplastic or due to pancreatic mass or pancreatitis related diabetes type 3C like. So
okay.
Anyway, the adequate glycemic control is very important. HbA1c 9.2 is very poor glycemic control. So preferably either we'll refer to physician or endocrinologist to make sure that diabetes control should be adequate.
What about in such cases, she is recently diagnosed. Is there a possibility that there is a pancreatic exocrine insufficiency in such cases, and how do we go about that?
It can be there, but basically we'll differentiate these two things in two parts. One is endocrine deficiency, which is a diabetes,
yes.
And next is a exocrine deficiency, which is actually enzyme deficiency, which is very rare. Even okay. In chronic pancreatitis, with a calcified chronic pancreatitis with a, I mean atrophic pancreas, 95% of the patients will not have a clinical exocrine deficiency and will not require PERT, that is pancreatic enzyme replacement therapy. So I don't think right now I will advise any PERT here, but definitely diabetes control is required.
Okay. So as we know from the CT findings, this is clearly inoperable because celiac axis is encasement is more than 180 degrees. So here the choice between the chemotherapy, we definitely will need some neoadjuvant therapy. In such cases, neoadjuvant chemoradiation will take a little backseat and we'll consider neoadjuvant chemotherapy first. There are two options. Again, FOLFIRINOX is kind of gold standard for pancreatic cancers, but there is a new regimen that is coming up is liposomal irinotecan along with fluorouracil and leucovorin. There is one trial, this is NeoPan trial, which is phase 3 trial, which compared FOLFIRINOX with gemcitabine in locally advanced pancreatic cancer. As we can see, the median progression-free survival in such patients is very low. With FOLFIRINOX is 9.7 and gemcitabine is 7.7 months, and median overall survival is 15.7 and with gemcitabine. So these are whether you do FOLFIRINOX or FOLFIRINOX, it's the survival is almost similar. There is not much difference in overall survival, but progression-free survival is little better with FOLFIRINOX. There is another trial which is Napoli 3 trial. It is again nab-paclitaxel gemcitabine versus NAL-IRINOX in treatment-naive metastatic pancreatic ductal carcinoma. Let me remind you, this is not a trial for locally advanced. It is used for metastatic tumors, and it's a very good trial with large number of patients. Median follow-up is 16.1 month. Overall survival is little better with NAL-IRINOX as compared to gemcitabine based trial, but it comes with grade 3, as we can see here, with the grade 3 or higher treatment related adverse events are seen in 87% of the patients. Even though death rate is less, but the number of side effects are very high, and this trial has almost considered this NAL-IRINOX regimen as a kind of first reference regimen. I would skip the next case in view of time. I will have some take-home messages here. The radiological response criteria are not exactly good in post-neoadjuvant therapy in pancreatic cancer. So the CA 19.9 trajectory it matters more. This molecular profiling is no longer academic. It is, it is helping us to make surgical decisions. So do you have anything to say, sir? Any take-home message for?
It's a multi-disciplinary management. Not a single person is going to decide. Everyone is needed with their full efforts. Surgeon, medical gastroenterologist, most important pathologist and radiologist.
Yes,
so
these are very
everyone's
important.
opinion is very much important because resectability, borderline resectability, locally advanced and distant advanced. So there are protocols, so everyone is required in this.
So is medical gastroenterology, right from EUS, staging, then tissue sampling.
Even palliation, ERCP.
Even in palliation, we can have even sometimes celiac plexus block can be considered through endoscopic means. And for pancreatic surgeons or during surgery, it is best to know when not to operate and not to treat. And to treat, if we want to treat, our team, as sir said, is the most important member. I mean, all the members are important in the team. These are the trials that are, important in shaping this treatment. So in pancreatic cancer, the best outcome is always a team decision. Thank you. Any questions I would like to take if there are any questions? Thank you. I'm sorry my team members are not there, but then I can't help it. Thank you.
These are the hazards of our profession, sir.
Okay.
Everybody will understand.
Thank you. Mm-hmm. Yes.
So what two facts I would like to highlight is, one is the development of diabetes.
Yes.
And the other thing is the CA 19.9 as the tumor marker. So do you advise that any patient with diabetes should have this tumor marker estimation as a routine basis, or what do you advise this? Because diabetes with pancreatic cancer is not also a rare entity.
Mm-hmm.
We have seen many patients, but usually what happens is that when they are detected, they are almost beyond treatment.
Yes.
So diabetes and the tumor marker, what should be the correlation?
Sir, actually, the number of diabetic patients in India is so huge that it won't be advisable to do CA 19.9 as a screening tool for each and every diabetic patient. Even though the occurrence of diabetes with pancreatic tumors is quite common, as I mentioned in this case, but to subject each and every diabetic patient on diagnosis for this screening type of thing, I don't think it is advisable. What do you think, sir?
In such a cases where is highly suspicious new onset diabetes, screening ultrasound abdomen will give a lot of answers. If there is a pancreatic head mass, then you can go ahead with the CA19-9, US guided FNAC and all. Simple ultrasound abdomen can do the work rather than screening tumor markers.
And another thing, sir, CA 19.9 is not a diagnostic tool, as sir said, that USG or USFNA or other things are more into diagnosis. This is a prognostic marker. Once we know the diagnosis of pancreatic cancer, then our prognosis will depend on this CA 19.9. But that is not a diagnostic tool per se, because it is increased in a lot of other conditions also, like chronic pancreatitis. It might be raised also in acute pancreatitis. It might be raised also. We cannot, investigate further just based on 19.9 report. Yes, yes. That's why sir said it is difficult to manage. Absolutely. Yes.
Diabetes because of a pancreatic tumor, he should have a tumor marker estimation, because it may give some indication. Otherwise, the point where he is diagnosed, it is beyond treatment.
Okay. So, subjecting each and every patient for this tumor marker is something which I really don't think should be done.
More than this, as Sandeep said, ultrasound abdomen will diagnose more compared
rather
to the
than
CA19. CA19 is maybe a false positive, but sir, in 50% of the stage 1 cancer, CA19 is
CA 19.9 will not be raised, sir, in small tumors.
So ultrasound will help more in diagnosing the early stage cancer rather than the CA19. It is just it has got more predictive value, whether it is responding to
and
tumor
it's
or
more cost effective. If we'll see the CA19-9 cost, ultrasound
that's
will be
okay,
more
but
cost effective.
ultrasound will diagnose
screening tool.
Early cancers better.
It will take up early cancer rather than CA 19.9.
So the take-home message, Dr. Dheeraj, the standard management of borderline resectable pancreatic cancer, that is BRPC, is a multidisciplinary approach involving a surgical oncology, medical oncology, radiation oncology, gastroenterologist and radiology, right?
Yes.
So the current treatment sequence is diagnosis, whatever by radiologist, pathologist, oncologist, gastroenterologist, then the neoadjuvant chemotherapy, plus or minus chemoradiation, then restaging, followed by surgical resection if feasible, adjuvant chemotherapy and surveillance. So you didn't talk about the follow-up after the surgery in a few words.
Okay. Actually, the follow-up is, after surgery, if it is locally advanced or borderline resectable, the standard of care is adjuvant chemotherapy, and followed by follow-up is like just like other tumors. We usually follow up maybe 3 months, every 3 months for 2 years, and 6 months, every 6 months I would like to get a CT done. or maybe consider PET also if patient is symptomatic, or if I find something on CT, if any abnormality, I would like to do PET also.
And sir, tumor marker like monitoring of tumor marker CA99.
It will be every 6 months.
Every 6 months. And additional nutritional support or pancreatic enzymes like?
No, as sir said, see, if the adequate pancreatic tissue is remaining, which most of the time is the case,
If it is in the tail of pancreas?
then the head will be remaining, sir. We will be removing only the tail part. Distal pancreatectomy will be done. So in such cases, the enzymatic replacement, as sir said, it is very rarely required. But in case if it is required, it goes into standard format. I think sir will be able to put more light on this.
Enzyme preparation.
Sorry?
Enzyme preparations.
Exactly, that's what sir just mentioned, that this thing.
5% of the tissues are also sufficient to make actually enzymes which are required for the digestion. The main treatment for nutrition is protein and calorie requirement for such kind of patients. Those who underwent procedures or whatever in operation on pancreatic hemolysis, they're very catching sick. So nutrition part is more towards the protein, calorie and all management rather than pancreatic enzyme replacement therapy. Yeah.
Yes. Diabetic management.
Diabetic management is just like our routine diabetic management, because those are not, just because of surgery or this thing, they are not, I mean, it's not something different for these tumors. The only thing which I like to mention, that during such major resections, we usually put a feeding jejunostomy, and we can start the patient enteral feeding very early, rather than base ourselves onto parenteral nutrition or this enzyme replacement. It is best to consider enteral nutrition as early as possible. So usually these patients are put on feeding jejunostomy very early. I mean, immediately intraop also, intraop only we put feeding jejunostomy, and continue feeding maybe in 2 or 3 days the feeding is started.
Okay. Thank you.
Thank you, sir. Now I request the chair to kindly felicitate Dr. Dheeraj. Chairpersons, please felicitate Dr. Dheeraj Khadagban and Dr. Sandeep Patil. Please give them a big round of applause. I request Dr. Chinmay to felicitate the chair. Respect. Kindly also felicitate Sandeep sir. Yes. Thank you, sir. Thank you, Chinmay sir. Now we'll be moving towards the inauguration ceremony. I request all the members who are waiting outside to kindly come and sit in the hall. I request all the people waiting outside to come inside the hall for the inauguration. I request the stage committee to kindly put up chairs and tables on the stage for the inauguration function.
consultant endocrinologist, came.
First of all, I would like to thank the pharmacology and the mechanism of
Good afternoon. Delegates who are waiting outside the hall are on behalf of the Scientific Society of Amscon and the host IMA Karad, I welcome all the dignitaries on the dais. Now I request Dr. Jayant Patil sir to kindly give us the introduction of all the dignitaries. First, I would like to introduce Sir himself before proceeding. Sir is the Vice President of our IMA Karad. He is the convener of the Road Safety and COLS Committee of IMA Maharashtra State. Dr. Jayant Patil sir, I request you to kindly first and foremost introduce our chief guest, Dr. Santosh Kulkarni sir. Along with this, I request our President of IMA, Dr. Dinesh Oswal sir, to kindly welcome sir and felicitate him.
Thank you, ma'am. Good afternoon, one and all. Dignitaries on the dais, esteemed faculties, and enthusiastic dear delegates. It is my privilege to welcome our chief guest and state office bearers, distinguished leaders, and stalwarts strengthened our organization through their vision, dedication, and leadership. It is my honor to introduce our esteemed chief guest. I request your warm applause as we welcome Dr. Santosh Kulkarni sir, Honorable State President, IMA Maharashtra State. He has served in the Indian Medical Association with unwavering commitment over the years. His journey in IMA reflects hard work, integrity, and deep sense of responsibility. He has made significant contributions involving in numerous committees at state and national level.
Please give them a big round of applause. Now I request Dr. Jayant Patil sir to kindly introduce Dr. Ramesh Bharate sir.
We are equally honored with presence of Dr. Ramesh Bharate sir, Chairman IMA AMS Maharashtra State. Sir is chest physician from Latur, Professor and Head Government Medical College Latur. He is an academic in charge Indian Chest Society. He is the past President IMA Latur, past Sports Chairman IMA Maharashtra State.
I request Dr. Vaibhav Kumar Chavan sir to kindly felicitate Dr. Bharate sir. Thank you, sir.
Our next dignitary, Dr. Dinesh Oswal, sir, President, IMA Karar. Shailaja, madam.
Yes. I request Dr. Ramakant Moite, sir, to kindly felicitate Dr. Dinesh Oswal, sir, who is our President, IMA. Next, I request Dr.
Dr. Anil Desai, sir, immediate past President, IMA Karar.
Sir, Dr. Vaibhav Kumar Sawan has to be felicitated.
Yes, sorry. Yes. Dr. Vaibhav Kumar Chauhan from our own branch,
Yes.
past President, IMA Karar, past Joint Secretary, IMA Maharashtra State, now Co-Chairman, IMA AMS Maharashtra State, Organizing Chairman of Amscon 2026.
I request Dr. Santosh Kulkarni, sir, to kindly felicitate Dr. Vijay Kumar, Vaibhav Kumar Sawan, sir.
Next dignitary, Dr. Anil Desai, sir, immediate past President, IMA Karar.
I request Dr. Dinesh Bhokre, sir, to kindly felicitate Dr. Anil Desai, sir.
Next, Dr. Rahul Pashe, sir, Honorary Secretary, IMA Karar, and Organizing Secretary, Amscon 2026.
Dr. Mangesh Joshi, sir, please felicitate Dr. Fase, sir.
Next. Next is Dr. Anga Rajguru, ma'am, immediate past Honorary Secretary, IMA Karar, Co-Chairman, National Safe Sound and Initiative Committee, IMA Maharashtra State.
I request Dr. Sadhna Molkar, ma'am, to kindly felicitate madam.
Next, Dr. Savita Devkar, ma'am, Honorary Treasurer, IMA Karar, Organizing Treasurer, Amscon 2026.
I request Dr. Amal Patil, sir, to kindly felicitate ma'am.
Next, Dr. Manoj Joshi, Joint Organizing Secretary, Amscon 2026.
I request Dr. Shekhar Kognulkar, sir, to kindly felicitate Dr. Joshi, sir.
Dr. Tulsidas Patil, sir, Senior Executive Member of Public Health Awareness Committee, IMA Maharashtra State.
I request Dr. Abhijit Patil, sir, to kindly felicitate Dr. Tulsidas Patil. Next, I request Dr. Sandeep Yadav, sir, to kindly felicitate Dr. Jayavant Patil, sir. He has already been introduced. Please give them a big round of applause.
The remaining
Thank
executive
you.
members are Dr. Abhijit Patil, Dr. Shekhar Kognulkar, Dr. Dattatreya Joshi, Dr. Moite, sir, and Dr. Dinesh Bhokre. Sorry, a brief about the AMS, the Academy of Medical Specialties. AMS is the academic wing of the Indian Medical Association. It brings together specialists from diverse medical disciplines to promote continuing medical education, interdisciplinary collaboration, research, and the exchange of scientific knowledge. Through conferences, workshops, and academic activities, the Academy strives to enhance professional excellence, encouraging lifelong learning and ultimately improve patient care. AMS serves as a common platform where specialists learn, collaborate, and grow together for the advancement of medicine. Hence, the theme for the conference is Empowering Doctors, Elevating Care. As saying goes, when knowledge is shared, wisdom multiplies. When minds connect, possibilities become limitless. I am sure today's deliberations, discussions, and interactions will inspire us all and contribute significantly towards our professional journey. Jai IMA, long live IMA. Madam, charge to you.
Thank you, sir. Thank you so much for these kind words. Now I request all the dignitaries to come forward for watering the plant. Dr. Santosh Kulkarni, sir, please come forward for watering the plant.
Dr. Bharate sir, Dr. Sawan sir, Dr. Koswal, Dr. Fase. The IMA is pledged to reducing all our carbon footprints. So this is our way of securing our own health. Dr. Savita ma'am.
Very important person, without whose approval this conference couldn't have been okayed. I request all the dignitaries on the dais to please stand up for a group photo. Some of you all can come ahead, the first row. Yes, please. Please come forward. Thank you. All of you all can be seated. Thank you everyone. Now I request Dr. Rahul Fase sir to kindly deliver the IMA prayer.
Good afternoon, everybody. I request all of you to stand up on their positions and please follow me, the IMA prayer. May everybody be happy. May everybody be healthy.
May everyone be healthy.
May everybody be free from pain.
May everybody be free from pain.
May everybody be free from sorrow.
May everybody be free from sorrow.
May we be the healing cure.
May we be the healing cure.
Beyond every greed and lure.
Beyond every greed and lure.
Thank you all of you.
Thank
now,
you. Please remain standing. Now Dr. Fase will be delivering the IMA oath. We will not be following him, but we will be standing for the same. Thank you everyone.
we, the members of Indian Medical Association,
stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you.
Thank you everyone. You can all be seated. We will be moving ahead. I request Dr. Vaibhav Kumar Chavan to kindly give his introductory speech as the organizing chairman of this Amscon 2026.
Good afternoon. नमस्कार. आज या ठिकाणी कराडमध्ये ॲम्स्कॉन कॉन्फरन्स आपण घेतलेली आहे. या कॉन्फरन्ससाठी आमच्या IMA बॉडीने गेले 15 दिवस सगळ्यांनीच खूप प्रयत्न केले आणि त्याचं फळ आज सगळ्यांच्या समोर आहे. कुलकर्णी सर आणि बराटे सर दोघांनी आपलं कौतुक केले. फक्त काही कारणास्तव पाऊस मुंबईमध्ये वगैरे जास्त असल्यामुळं आपल्या IMAचे जे सेक्रेटरी आहेत, ट्रेझरर आहेत स्टेट IMAचे, ते पदाधिकारी पोहोचू शकले नाहीत. तसेच नेक्स्ट IMA प्रेसिडेंट आहेत गिरी मॅडम, त्या पण नागपूरवरून येऊ शकल्या नाहीत. आणि आमचे AMSचे सेक्रेटरी मॅडम आहेत आव्हाड मॅडम, त्या पण नाशिकवरून येऊ शकल्या नाहीत. आम्ही सगळ्यांसाठी प्रयत्न केले होते की सगळ्यांनी इथं यावं, या कॉन्फरन्समध्ये सहभागी व्हावं. तर मी थोडक्यात कराड IMAबद्दल बराटे सरांना, कुलकर्णी सरांना थोडंसं कल्पना देईन की 2004मध्ये डॉक्टर अविनाश पाटील सरांच्या अध्यक्षतेखाली आम्ही कराड IMA त्यापूर्वी होती कराडमध्ये, पण त्याच्यापूर्वी 10 वर्ष थोड्याशा ॲक्टिव्हिटी कमी झाल्यामुळे नंतर पाटील सरांच्या कारकिर्दीमध्ये परत IMA पुनर्जीवित झाली. आणि त्यानंतर सर प्रेसिडेंट होते आणि मी सेक्रेटरी होतो. त्याच्यानंतर मग आमच्याकडे त्यावेळेला काहीच फंड नव्हते, तर सुरुवातीला 1000 रुपये पर इयर याप्रमाणे आम्ही फंड घ्यायला सुरुवात केली आणि IMAच्या ॲक्टिव्हिटीज चालू केल्या. आणि त्यानंतर आमच्या IMA खूपच लवकर ग्रो होत गेली. त्याच्यापूर्वी 135 मेंबर होते स्टेट IMAचे, तर आज आपली स्ट्रेंथ 400वर गेलेली आहे. अजूनही आपल्यातील बरेच जण स्टेट IMAचे मेंबर झालेले नाही आहेत, आमचे प्रयत्न चालू आहेत. तर त्यांनी देखील यामध्ये सहभागी होऊन आणि आपली स्ट्रेंथ वाढवावी, जेणेकरून काय होतं की ज्या वेळेला स्टेटचे इलेक्शन असतात त्यावेळेला आपल्या ब्रँचचं महत्त्व खूप वाढतं. तर सरांना मी सांगू इच्छितो की आम्ही 10-12 वर्षापूर्वी डॉक्टर उत्तुरे सर, डॉक्टर लेले सर हे स्टेट IMAमध्ये असताना आम्ही IDCON कॉन्फरन्स कराडमध्ये घेतली होती 2 दिवसाची, आणि ती आमच्या बॉडीनं अशी सक्सेसफुल IDCON कॉन्फरन्स करून दाखवली होती. मला फक्त एकच सांगणं आहे की सरांनी इन्सिस्ट केलं होतं, बराटे सरांनी आपले सातारा जिल्ह्याचे SP साहेब आहेत त्यांना आज इन्व्हाइट केलं होतं, पण ते काही कारणास्तव प्रमुख पाहुणे म्हणून उपस्थित राहू शकले नाहीत. आणि कुलकर्णी सरांनी रिक्वेस्ट केलं होतं की आपले या भागातले आमदार आहेत अतुल बाबा, त्यांना देखील इन्व्हाइट करावं, पण ते आज कराडमध्ये नसल्यामुळं आपल्याला अवेलेबल होऊ शकले नाहीत. तर सरांना मला एवढं सांगायचं आहे की आमच्या कराड IMAमध्ये गेली 15-20 वर्ष झाली कराडमध्ये कुठलाही मोठा प्रॉब्लेम आलेला नाही. त्याला कारण आम्ही सगळे एकत्र आहोत. कोणी कोणाबद्दल काही वाईट बोलत नाही. मेडिकल फील्ड अनप्रेडिक्टेबल आहे. सकाळी जी केस आपण बघितलेली असती त्याच्यामध्ये संध्याकाळी वेगळे चेंजेस असतात. त्यामुळं कोणी कोणाला दुसऱ्याला म्हणून चालत नाही की त्याला काल कसं काय कळलं नाही, या पेशंटबद्दल. तर प्रत्येकाकडे ज्या वेळेला तो पेशंट प्रेझेंट होतो त्यावेळेला त्याचं प्रेझेंटेशन वेगळं असतं. त्यामुळं दुसऱ्याबद्दल वाईट बोलून त्यातून आपल्याला काही मिळणार नाही. आणि त्यामुळं आमचे जे हेवे देवे आहेत ते कुणाचेच नाही आहेत. प्रत्येक डिपार्टमेंट जे आहेत त्यांचे स्वतःचे डिपार्टमेंटच्या मीटिंग्स वेगवेगळ्या होतात. ते एकमेकांचे बरोबर मित्रासारखे बोलतात. जरी पेशंट बाउन्स झाला तरी त्याची चर्चा संध्याकाळी एकमेकाबरोबर होते. त्यामुळं पेशंट जे आपल्यामध्ये भांडणं लावायचा प्रयत्न करतात की त्या डॉक्टरांनी असं केलं तसं केलं, तर तो भाग आमच्यामध्ये नाही आहे. त्यामुळं शक्यतो आम्हाला लोकल पुढाऱ्यांचा पण देखील जास्त गरज पडत नाही. हे एक गोष्ट आम्ही अभिमानाने सांगेन की इतर ठिकाणी जे मदत घ्यावी लागते, काय प्रॉब्लेम आले म्हणून मदत घ्यावी लागते, तर ती पण आम्हाला घ्यावी लागत नाही. तर हे थोडक्यात कराड IMA मी बोललो. आज AMSचा मी स्टेट IMAचा व्हाईस प्रेसिडेंट आहे. बराटे सर चेअरमन आहेत. तर AMSची एक कॉन्फरन्स कराडमध्ये व्हावी हे कुलकर्णी सरांची इच्छा होती, म्हणून आपण हा सगळा प्रयत्न केला. तर इथून मी सगळ्यांचे आभार मानतो आणि माझे भाषण संपवतो. थँक्यू.
Thank you, sir. As you all know that we had a poster presentation competition with 2 divisions. One was for the medicine and one was for the pediatric division. We have the guest of honor have selected the prizes. Now I will be declaring it. In the medicine department, the 3rd prize goes to Dr. Rushil Patel. He has done a mixed connective tissue disorder presenting with pleural effusion case report for his poster. I request Dr. Rushil to kindly come on stage. Is Dr. Rushil there? No. Okay, fine. Jayji. Okay, the next prize, 2nd prize goes to, fine. Okay, if the presenters are not here, then we'll proceed with the inauguration, further aspects of the inauguration. Now I request Dr. Ramesh Bharate sir to kindly give us his guest talk and say, inspire us with a few words.
Respected dignitaries on the dais, President of IMA Maharashtra, respected Dr. Santosh Kulkarni sir, President of IMA Karad, Dr. Dinesh Oswal sir, Secretary of IMA Karad, Dr. Rahul Phase sir, Organizing Chairman and Co-Chairman of IMA AMS Maharashtra, my dear friend Dr. Vaibhav Chavan sir, all the office bearers of IMA Karad, all the delegates of IMA Karad branch and all the IMA members. Dear friends, it's a privilege to have such a wonderful gathering here. Dr. Chavan sir was persistently insisting, sir, आमच्याकडे कॉन्फरन्स हवी आहे, आम्हाला घ्यायची आहे. तर याच्यातूनच त्यांचा आग्रह आणि त्यांची या कॉन्फरन्सबद्दलची आपुलकी दिसून येते. 400 मेंबर्स असणारी ब्रँच स्टेट कॉन्फरन्स घेते म्हणजे ही खूपच कौतुकास्पद बाब आहे. याबद्दल मी आपले सर्वांचे परत एकदा टाळ्या वाजवून कौतुक करतो. Kulkarni sir, IMA AMS Maharashtra is doing well. In February 2026, we have conducted one regional conference at Latur, which was also successful, and near about 365 delegates attended that meeting. Being a pulmonologist, the conference was mainly focused on respiratory diseases, and I am very happy to see even the inauguration ceremony was conducted without light lamponing the plantation and powering the water. That is a good sign for maintaining the environment, and we are it's a sign to show the society that how the doctors are sensible about the environment. Sir, IMA AMS is conducting various fellowship courses. In that fellowship course in pediatrics, fellowship in TB and chest diseases, adolescent health, geriatric medicine, then HIV and AIDS, family planning, environmental and occupational health, reproductive and child health, psychiatry and psychosexual medicine, medical negligence and CPA, clinical diabetes, clinical cardiology, rheumatology, and radiology. These are the various fellowship courses which are successfully conducted in various parts of the country. So, and the registration fees of IMA AMS is 1,000 rupees and 18% GST charges. So, being a IMA AMS chairman, it's my humble request to all the consultants of all branches, kindly enroll yourself as a IMA AMS member so that we can conduct such kind of specialty branches conference across the Maharashtra. I will not speak on the other administrative issue because respected president is a kind knowledgeable person and he is always ready to help our members 24/7 days. So yesterday he has arrived from Chandrapur. It shows his enthusiasm and his his supportive power to enhance and to encourage all the IMA members of the Maharashtra. With these few words, I will again congratulate all the members of the IMA Karad and organizing team of the IMA Karad. Thanks to all the members for felicitations and conducting such a wonderful conference. Thank you. Jai Hind, Jai IMA.
Thank you, sir. Thank you for appreciating Karad IMA for our role in reducing the carbon footprints in this world. Thank you so much, sir. Now I request President IMA MS Dr. Santosh Kulkarni sir to kindly deliver his talk.
धन्यवाद मॅडम. IMA कराडच्या राज्यस्तरीय Amscon 2026 वैद्यकीय परिषदेमध्ये आपल्या सर्वांचं मनपूर्वक स्वागत करतो. खरं बघायला गेलं तर आत्ताच वैभव चव्हाण त्यांनी संपूर्ण IMA कराड ब्रँचबद्दल इतिहास सांगितलेला आहे आणि खरंच खूप चांगल्या पद्धतीने ऑडिओ व्हिज्युअल इफेक्ट्स असतील, वेगवेगळ्या विषयाचे सुपर स्पेशालिस्ट डॉक्टर्स आज आपल्या सर्वांना मार्गदर्शन करत आहेत आणि खूप चांगल्या पद्धतीची कॉन्फरन्स कराडमध्ये IMA कराडने आयोजित केली. त्याबद्दल सर्वप्रथम मी IMA कराडच्या संपूर्ण टीमचं मी मनपूर्वक अभिनंदन करतो. आजच्या Amscon कार्यक्रमास उपस्थित IMA महाराष्ट्र राज्याचे AMS विंगचे महाराष्ट्र राज्याचे चेअरमन आमचे मित्र डॉक्टर रमेश भराटे सर, को चेअरमन आणि आजच्या या कॉन्फरन्सचे ऑर्गनायझिंग चेअरमन डॉक्टर वैभव चव्हाण, त्याचबरोबर IMA कराडचे अध्यक्ष डॉक्टर दिनेश सर, सेक्रेटरी आमचे मित्र डॉक्टर राहुल फासे, ट्रेझरर डॉक्टर सविता देवकर मॅडम, त्याचबरोबर व्हाईस प्रेसिडेंट आणि महाराष्ट्र राज्याचे रोड सेफ्टी आणि कोल्सचे को चेअरमन डॉक्टर जयवंत पाटील, नॅशनल सेफ साऊंड सर्व्हिस महाराष्ट्र राज्य कमिटीच्या को चेअरमन डॉक्टर अनघा राजगुरू मॅडम आणि फास्ट सेक्रेटरी IMA कराड, पब्लिक हेल्थ अवेअरनेस कमिटीचे आमचे मार्गदर्शक डॉक्टर तुळशीदास पाटील सर, त्याचबरोबर आमचे मित्र डॉक्टर भोकरे व्हाईस प्रेसिडेंट आणि आजच्या MOC डॉक्टर कुलकर्णी मॅडम आणि स्टेजवरील आमचे डॉक्टर रमाकांत मोहिते सर आणि सर्वच आजच्या या वैद्यकीय परिषदेसाठी उपस्थित असलेले सर्व ऑफिस बेरर्स, सर्व माझे डॉक्टर बंधू भगिनींनो आणि आजच्या या कार्यक्रमामध्ये ज्यांनी मार्गदर्शन केलं ते सुपर स्पेशालिस्ट सर्व माझे डॉक्टर मित्र, यांचंही मी मनपूर्वक अभिनंदन करतो. जास्त वेळ घेणार नाही, खरं बघायला गेलं तर जेवायची वेळ झालेली आहे आणि कार्यक्रमसुद्धा खूप उशीर होत चाललेला आहे. मुळात IMA AMS बद्दल डॉक्टर भराटे सरांनी सांगितलेलं की AMSचं मेंबर काय व्हावं, त्याच्या काय फेलोशिप आहेत आणि कशा पद्धतीने आपण त्याला अप्लाय करायचं. महाराष्ट्र राज्याच्या वेगवेगळ्या विंग्स आहेत. HB आहे, AMS आहे, CGP आहे, सोशल सेक्रेटरी आहे, PPS आहे. पण मी खरं अभिमानाने सगळ्यासमोर सांगतो की आज 2026मध्ये 25-26च्या अध्यक्षाच्या कार्यकाळामध्ये सर्वात जास्त जर कुठल्या विंगनी काम केलं असेल तर ते डॉक्टर रमेश भराटे सर चेअरमन आणि डॉक्टर वैभव चव्हाण को चेअरमन असलेल्या IMA AMS विंगनी केलेलं आहे. कारण गेल्या वर्षभरामध्ये जसा ह्यांनी चार्ज घेतलेला आहे त्या पद्धतीने लातूरमध्ये पल्मो 26 अशा पद्धतीची पण कॉन्फरन्स घेतलेली होती. त्याही ठिकाणी कॉन्फरन्ससोबत सध्याचे जो ज्वलंत विषय आहेत याच्याबद्दलसुद्धा पत्रकार परिषद घेतली. आत्ता सध्या को चेअरमन डॉक्टर वैभव चव्हाण यांनीसुद्धा आज कराडमध्ये म्हणजे 400ची ब्रँचचा संबंध नाही आहे. लग्नामध्ये बँड वाजवायचे किती लोक वापरले ह्याच्यापेक्षा वाजवणारे किती महत्त्वाचे असतात. खूप मोठा बँड लावतो आपण 50चा, पण त्याच्यामध्ये वाजवणारे 4-5च असतात. आणि ह्या सगळ्या लोकांमध्ये जे काही मेंबर्स आहेत हे सगळेच म्हणजे इवन मेंबर्सनी पण मदत केलेली आहे आणि सर्व IMA कराडच्या टीमनीसुद्धा मदत केलेली आहे. आणि वैभव चव्हाण सरांनी सांगितले की त्यांना इथं कुठल्याच पॉलिटिकल लोकांची पण गरज पडत नाही. खरंच अभिनंदन IMA कराडचं, कारण अशी जी एकता आहे अशीच अबाधित राहो ही सद्गुरूचरणी प्रार्थना करतो. तुम्हाला कुठल्याच पद्धतीच्या अडचणी येऊ नये. परंतु सध्या ज्या काही गोष्टी आत्ता महाराष्ट्रामध्ये घडत आहेत त्याबद्दल थोडक्यात मी आपल्याला सांगू इच्छितो की सर्वप्रथम तर आपण गेल्या जूनमध्ये आपण महाराष्ट्र राज्याचे पोलीस महासंचालक जे डॉक्टर दाते साहेब आहेत आणि विशेष पोलीस महानिरीक्षक निशित शर्मा यांना भेटून आपण आत्ता सध्या जे महाराष्ट्रामध्ये ठीक आहे कराडमध्ये नाही आहे परंतु बऱ्याचशा ठिकाणी हॉस्पिटलमध्ये डेथ झाली. मोस्टली ह्या सगळे जे प्रकरणं होतात ते बिलापोटी होतात. पेशंट चांगला झाला तोपर्यंत काही नाही, पण एखादा पेशंट डेथ झाला तर ते बिल वाचवण्यासाठी निग्लिजन्सच्या केसेस मॅक्झिमम होतात. आणि त्याच्यामुळे जे होणाऱ्या गोष्टी आहेत की पेशंटची डेड बॉडी हॉस्पिटलमधनं घेऊन न जाणे, हॉस्पिटलच्या पुढे ठेवून आंदोलन करणे किंवा पोलीस स्टेशनपुढे घेऊन आंदोलन करणे आणि त्या काळामध्ये मग मीडियाचं प्रेशर, राजकीय लोकांचं प्रेशर आणि या सर्व गोष्टीमुळं ज्या पद्धतीने डॉक्टरांवर बऱ्याचशा ठिकाणी गुन्हे दाखल होतात किंवा कुठल्याही मेडिकल बोर्डवरती केस न पाठवता ज्या पद्धतीने डॉक्टरांवर कारवाई केली जाते, याच्यासाठी आम्ही महाराष्ट्र राज्य IMAच्या वतीने आणि आपल्या मेडिकल लिगल टीमच्या वतीने आपण पोलीस महासंचालकाला पत्र दिलं. 1992चा गृह विभागाचा पण GR आहे, 2010चा आरोग्य विभागाचा पण GR आहे. परंतु बऱ्याचदा काय होतं, हे आपण GR स्वतःहून पोलीस स्टेशनमध्ये नेऊन देणं, त्याच्यापेक्षा जर त्यांच्याच वरिष्ठांकडनं जर पत्र आलं तर ते त्यांच्याकडे इनवर्डला येतं आणि त्यांच्याकडे ते माहितीस्तव असतं. म्हणून आम्ही आत्ता ज्यावेळेस मीटिंग घेतली पोलीस महासंचालकांसोबत, तर त्यावेळेस मी त्यांना ह्या सगळ्या गोष्टी सांगितल्या की आपल्याकडे जे ॲक्ट आहेत, आता गायनेकोलॉजिस्ट आहेत, रेडिओलॉजिस्ट आहेत, पिडियाट्रिशियन आहेत, सगळ्याला माहिती आहे की पॉक्सो अंतर्गत कशा पद्धतीच्या सध्या अडचणी आहेत. जे गायनेकोलॉजिस्ट आहेत त्यांना ART सेंटर्सची नोंदणीमध्ये किती अडचणी आहेत आणि नंतर IVF सेंटर्स चालवताना काय काय अडचणी होतात. आत्ताच भिवंडीचं पण प्रकरण तुम्ही पाहिलं. त्याच्यामुळे MTP ॲक्ट्स आहेत, व्हायलन्स ॲक्ट आहे, वेगवेगळे जे ॲक्ट्स आहेत त्याची माहिती PSI जे फ्रेश असतात त्यांना असते, IPS लोकांना असते, DYSP लोकांना असते, पण हे इन्व्हेस्टिगेटिंग ऑफिसर नसतात. इन्व्हेस्टिगेटिंग ऑफिसर हे हेड कॉन्स्टेबल ASI ह्या लेवलचे असतात आणि त्यांच्याकडे ह्या वेळोवेळी ह्या केसेस येत नसतात. त्याच्यामुळे आम्ही मेडिकल लिगल कमिटी IMA महाराष्ट्र स्टेटकडनं आम्ही पोलीस महासंचालकाला आणि गृह विभागाला विनंती केली की बाबा आमच्याकडे भरपूर तज्ज्ञ डॉक्टर्स आहेत, हे सर्व तज्ज्ञ डॉक्टर्स आम्ही पोलिसांचं ट्रेनिंग प्रत्येक जिल्ह्यामध्ये प्रत्येक तालुक्यामध्ये घेऊ. तुम्ही ते पोलीस आणि ते त्याबद्दल पब्लिक ते जे सरकारी वकील आहेत यांची तुम्ही जर अरेंजमेंट केली तर आमचे स्वतः IMAचे डॉक्टर्स वेगवेगळ्या विषयातले तज्ज्ञ डॉक्टर्स त्या ठिकाणी मार्गदर्शन करतील. त्या पद्धतीने त्यांनी पोलीस महासंचालकांनी पत्र काढलेलं आहे. वेगवेगळ्या गोष्टीमध्ये वेगवेगळ्या ॲक्टचं ट्रेनिंग देण्यासाठी आपले IMA मेंबर्स जिल्ह्याच्या ठिकाणी तालुक्याच्या ठिकाणी, इवन मी ते पत्र अध्यक्षांना आणि सेक्रेटरींना मी फॉरवर्ड करतो. ते पत्र तुम्ही आजच्या आज इथल्या DYSPला किंवा ॲडिशनल SP असेल इथं कराडसाठी, तर त्यांना तुम्ही ते नेऊन द्या आणि तुमच्या IMA कराडच्या माध्यमातून ही पहिली ॲक्टिव्हिटी करा तुम्ही की तुमच्यातले जे तज्ज्ञ डॉक्टर्स आहेत, आता आमचे मित्र आहेत डॉक्टर संदीप यादव सर आहेत, ते अँटीक्वॅकरीचे चेअरमन आहेत, बोगस डॉक्टर शोध समिती, स्वतः ते पॅथॉलॉजिस्ट मायक्रोबायोलॉजीचे अध्यक्ष आहेत. तर हे वेगवेगळे जे विषय आहेत, MTP असेल, बोगस डॉक्टर असेल, पॉक्सो असेल, ह्याच्यातले तुमच्या कराड IMAमधले तज्ज्ञ डॉक्टर्स तुम्ही फाइंड आउट करा. मी जे पत्र आपण जे पोलीस महासंचालकांकडून घेतलं आहे ते तुम्ही त्यांना देऊन त्या पोलिसांचं काही सरकारी वकील यांचं ट्रेनिंग तुम्ही कराड IMAमध्ये घ्या किंवा त्यांचे जिथे कुठं प्रशिक्षण केंद्र आहे त्या ठिकाणी घ्या. ते देखील तुम्हाला स्वतः कॉन्टॅक्ट करतील. ही पहिली गोष्ट. त्याच पत्रामध्ये त्यांनी अर्ध्या पॅरेग्राफमध्ये खूप चांगल्या पद्धतीने गाईडलाईन्स दिलेत, कारण आपण त्यांना विचारलेलं होतं की तुम्ही गाईडलाईन्ससुद्धा खाली पाठवा की एखाद्या पेशंट डॉक्टरांचा निग्लिजन्स झाला, एखाद्याची डेथ झाली तर पेशंटच्या नातेवाईकाबद्दल आपल्याला संवेदना आहेत, परंतु एखादा पेशंट समजा रोडवर खड्डे पडलेले आहेत, गाडीने जोरात येतो किंवा ड्रंक ड्राईव्ह करतो, तर तो आल्यानंतर जर समजा त्याची जर इमर्जन्सी पेशंट म्हणून आपल्या डॉक्टरने ट्रीट केली आणि ट्रीट केल्यानंतर जर पेशंट डेथ झाला तर त्या हॉस्पिटलपुढे तुम्ही गोंधळ घालता, तोडफोड करता. कधी ऐकण्यात नाही आहे की तो वर्षानुवर्ष दारू पितो, परंतु दारूच्या दुकानापुढे कुठल्या पेशंटच्या नातेवाईकाने आंदोलन केलेत असं कधी ऐकवण्यात नाही. किंवा एखाद्या कॉन्ट्रॅक्टरने रोड खराब केला आणि त्याच्यामुळं माझ्या मुलाचा ॲक्सिडेंट झाला म्हणून अशा कुठल्या कॉन्ट्रॅक्टरच्या पुढे ॲक्सिडेंट झाला म्हणून घरापुढे आंदोलन केलेलं नाहीत. पण हे सध्या ही फॅशन झालेली आहे. कमी काळात झटपट प्रसिद्धीसुद्धा त्या काही कार्यकर्त्यांना मिळते, म्हणून आपण ह्याला एक पायबंद घालावं म्हणून आपण एक गाईडलाईन्स पोलीस महासंचालकांनी घेतलेली. त्या पत्रामध्ये पहिल्या संपूर्ण पॅरेग्राफमध्ये हे 26 जूनचं पत्र आहे, त्याच्यामुळे रिसेंट पत्र आहे, ते सगळ्यांकडे तुम्ही ठेवा. त्याच्यामध्ये गाईडलाईन्स दिलेले आहेत की आपल्या GR प्रमाणे इवन सुप्रीम कोर्टाच्या गाईडलाईनप्रमाणे पोलिसांनी ह्या विषयात कशा पद्धतीची कारवाई करावी. हा विषय झाला मेडिकल निग्लिजन्सच्या बाबतीत. दुसरा आत्ता आपण सर्वजण पेपरमध्ये ऐकतायत तो म्हणजे महाराष्ट्र क्लिनिकल इस्टॅब्लिशमेंट ॲक्ट 2026. खरं बघायला गेलं तर हा जो विषय आहे हा 2002 पासून चालू आहे. महाराष्ट्र क्लिनिकल इस्टॅब्लिशमेंट ॲक्ट 2010ला सेंट्रल गव्हर्नमेंटनी पारित केलेला आहे, परंतु स्टेटचा हेल्थ हा स्टेटचा सब्जेक्ट आहे. तो कशा पद्धतीने त्यांनी अंमलात आणावा हा राज्य पातळीवरचा विषय असल्यामुळं मध्यंतरी 2020मध्ये सुद्धा एका विट्रान्स ऑफ पब्लिक ट्रान्सपरन्सी हेल्थ या NGOजनी कोर्टात केस केली सुप्रीम कोर्टात की डॉक्टरांचे जे काही रेट्स आहेत ICUचे रेट्स असतील, OPDचे रेट्स असतील, याचं कुठेतरी फिक्सेशन केलं पाहिजे. त्याच्यामुळे हे सगळ्या गोष्टी सुरू झाल्या. आणि 2020मध्ये त्याच्यामध्ये त्यांनी संदर्भ कुठला दिला तर आपला जो 2010 आणि त्याच्यानंतर अमेंडेड 2012 क्लिनिकल इस्टॅब्लिशमेंट ॲक्टमध्ये रूल 9मध्ये जे 2 आहे, एक रूल 9मध्ये एक आहे दरपत्रक लावणे. आपण सर्वच जण लावतो. मला वाटतं कराडमध्ये सुद्धा नुसतं दर नाही आहे, त्याच्यात 2 गोष्टी आहेत. रुग्णाचे हक्क पण आहेत आणि कर्तव्य पण आहे. कर्तव्यसुद्धा हायलाईट करून लावा. लोकांना फक्त हक्क मागायची अपेक्षा असते, कर्तव्य काय ते पण कळले पाहिजे. आणि त्याच्यासोबत प्रत्येक पायऱ्यावर जे आपला व्हायलन्स अगेन्स्ट डॉक्टर आहे त्याचंसुद्धा एक IMA कराडकडनं जर छोटं असं A4 साईजमध्ये ते लावलं तर ते पण लावू शकतो. परंतु ह्याच्यामध्ये त्यांनी रेट फिक्सेशनच्या संदर्भात जी PIL दाखल केली आणि ही केस होती 2020ची, त्यावेळेस काही नाही झालं. तशीच केस आपल्या हायकोर्टामध्ये कोविडच्या काळामध्ये पण टाकली होती. आणि प्रदीप अरोरा सर जे आहेत आपले नागपूरचे, त्याच्यामध्ये क्लिअर कट सांगितलेलं आहे की तुम्ही कोविडचे रेट फिक्स करू शकता, नॉन कोविड करू शकत नाही. त्याच्यामुळे रेट फिक्सेशन हे अद्याप कुठल्याही राज्यात झालेलं नाही. त्याच्यामुळे भीती बाळगायची काही गरज नाही आहे. आपल्याकडं सुप्रीम कोर्ट, हायकोर्ट सर्वाचे रेफरन्सेस आहेत. आणि महाराष्ट्र राज्य IMAने आपण क्लिनिकल इस्टॅब्लिशमेंट ॲक्ट ह्याच्या ड्राफ्टच्या संदर्भात अद्याप फक्त तो विधानसभेमध्ये सबमिट केलेला आहे, तो कॅबिनेटनी मंजूर केलेला आहे, पण त्याचं कायद्यात रूपांतर झालेलं नाही. त्याच्यामुळं तो जो बिल आहे आता पब्लिक डोमेनमध्ये येईल. जे प्रायव्हेट NGOज असतील, रुग्ण हक्क परिषद असतील, इतर NGOज असतील आणि डॉक्टरच्या वेगवेगळ्या संघटना, माझ्या सर्व स्पेशालिस्ट संघटनांना सुद्धा विनंती आहे, फक्त IMAच नाही तर सर्वांनी त्याच्यामध्ये जे जे ऑब्जेक्शनेबल गोष्टी आहेत, मराठीमध्ये आणि इंग्लिशमध्ये ड्राफ्ट आहेत, तो मी अध्यक्षांना शेअर करतो, तो तुम्ही वाचा. आणि प्रत्येक स्पेशालिस्ट संघटनेने सुद्धा राज्याच्या त्याच्यामध्ये ऑब्जेक्शन्स घ्या. त्याला एक 15 दिवस किंवा एक 3 आठवडे तुम्हाला दिले जातील. त्याच्यात जर तुम्ही आज ऑब्जेक्शन घेतले तर ते पुढे तो कायदा जो आहे त्याच्यामध्ये तो व्यवस्थिशीर आपल्याला डॉक्टर फ्रेंडली होईल. त्याच्यासाठी आपण येत्या बुधवारी आणि सोमवारी ऑनलाईन आणि बुधवारी ऑफलाईन आम्ही मुंबईमध्ये मीटिंग ठेवलेली आहे. वर्ड टू वर्ड प्रत्येक बिल जे आहे, महाराष्ट्र क्लिनिकल इस्टॅब्लिशमेंट बिल जे आहे, त्याच्यावर प्रत्येक गोष्टीला काय गोष्टीचं सगळ्याच गोष्टीला आपल्याला सरकारला विरोध करून चालणार नाही. शेवटी हे बिल येणार आहे, 100% येणार आहे. आपण किती विरोध केला तर त्याच्यामध्ये बिल येणार नाही का, तर येणार आहे. कारण हे 2014पासून चालू आहे. आणि याच्यामध्ये आता काय झालं की 2024ला सुप्रीम कोर्टाने आता क्लिअर कट फायनल वर्डिक्ट दिलेला आहे की एकतर तुम्ही स्टेटच्या लोकांनी ह्याच्यामध्ये तुम्ही रेट्सच्या संदर्भामध्ये म्हणा किंवा सगळे जे काही क्लिनिकल इस्टॅब्लिशमेंट आहे याच्यामध्ये तुम्ही स्वतः निर्णय घेऊन हा कायदा लागू करा. जे काही रेट्स आहेत ते बऱ्यापैकी फिक्स करा. नसेल तर आम्ही CGHSचे रेट्स डायरेक्ट अप्लाय करू. पण तसं करता येत नाही, कारण शेवटी आर्टिकल 19 जे आहे आपल्याला घटनेने जो प्रत्येकाला आपला आपला व्यवसाय करण्याचा, शेवटी किती जरी राजकारणी लोकांनी पेशंट म्हणत असले की आपला हा सेवा आहे वैद्यकीय सेवा, तर वैद्यकीय सेवा कायद्याच्याही दृष्टीने नाही आणि प्रशासकीय दृष्टीने नाही. आपली हा वैद्यकीय व्यवसाय आहे आणि प्रत्येकाला आपला आपला व्यवसाय भयमुक्त पद्धतीने आपापलं स्वतःचं कौटुंबिक आयुष्य जगून चांगल्या पद्धतीने, आणि ते म्हणजे जे काही आपल्याला नफा आहे, प्रत्येकजण व्यवसाय करतो तर काही तोट्यासाठी नाही, एवढं गुंतवणूक करतो. तर ह्या सगळ्या करण्याचा जो अधिकार आहे तो आपल्याला घटनेने आर्टिकल 19 प्रमाणे दिलेला आहे. जसा रुग्णाला राईट टू हेल्थ आहे तसं आपल्याला भयमुक्त पद्धतीने आपला आपला व्यवसाय करण्याचा अधिकार आहे. त्या सगळ्याचे रेफरन्स देऊन आपण त्या महाराष्ट्र क्लिनिकल इस्टॅब्लिशमेंट बिलासंदर्भात वर्ड टू वर्ड आपण ड्राफ्ट देत आहोत. आजसुद्धा मी आता हे आपलं इनॉग्रेशन संपल्यानंतर गारगोटी भुदरगडला आरोग्यमंत्री आंबेडकरांना जाऊन भेटणार आहोत. आणि आपले प्रधान सचिवसुद्धा डॉक्टर आहेत, डॉक्टर विनायक नपुन. हे सर्व जे आहेत ते सुप्रीम कोर्टाकडनं प्रेशर आलेले आहेत. इवन मध्यंतरी मी प्रत्येक व्हॉट्सअप ग्रुपला पण पाठवलं होतं, परत एकदा अध्यक्षांना पाठवतो की सुप्रीम कोर्टाच्या ICU गाईडलाईन्स पण आलेल्या आहेत. त्या गाईडलाईन्ससुद्धा सुप्रीम कोर्टाने दिलेल्या आहेत. तर ह्याच्यामध्ये सगळ्यात महत्त्वाचं काय क्लिनिकल इस्टॅब्लिशमेंटमध्ये, तर एक तर आहे गोल्डन आवरमध्ये ट्रीटमेंट. 2च मिनटात माझं भाषण संपवतो. गोल्डन आवर ट्रीटमेंट. गोल्डन आवर ट्रीटमेंटमध्ये हे बऱ्याचशा ज्या आहेत त्या ह्या राजकारणी लोकांच्या घोषणा आहेत. गोल्डन आवरमध्ये ट्रीटमेंट, एमर्जन्सी ट्रीटमेंट द्यायला आम्ही कधीच नकार देत नाही. एखादा रुग्ण गरीब असेल तर त्याला प्रथमोपचार करून जिथं कुठं हायर सेंटर आहे त्या ठिकाणी पाठवू. पण ह्या बिलामध्ये असं सांगितलेलं आहे की प्रत्येकाने तो पेशंट एमर्जन्सी ट्रीट करायचा आणि स्टॅबिलाईज करायचा. ट्रीटमेंट, एमर्जन्सी ट्रीटमेंट आणि स्टॅबिलायझेशन हे खूप गोष्ट वेगळी आहे. प्रथमोपचार ठीक आहे, आता मी स्वतः ऑप्थॉमॉलॉजिस्ट आहे, 8च्या नंतर मी डॉक्टर आहे हे सुद्धा विसरून जातो, पण माझ्या हॉस्पिटलमध्ये चुकून पेशंट येणार नाही. पण ह्या कायद्याचा दुरुपयोग करून जर एखाद्या नॉन एमर्जन्सी ब्रँचेसमध्ये किंवा एखाद्या आर्थोच्या हॉस्पिटलमध्ये एखादा पेशंट एमर्जन्सी गेला, MIचा गेला, तर त्यांनी ट्रीट केला आणि उद्या काही झालं तर त्याच्यातनं मेडिकल लिगलमधनं हे ॲक्ट सूट देणार आहे का? नाही आहे. एखाद्या MD मेडिसिननी सुद्धा एखादा MIचा पेशंट थ्रॉम्बोलाइज केला, पेशंट वाचला तर काय अडचण नाही, पण तो जर एक्सपायर झाला तर कोर्टाने कॉम्पेन्सेशन दिलेले आहेत की तुम्ही 40 किलोमीटरमध्ये कार्डिओलॉजिस्ट असताना तिकडे का रेफर केलं नाही. म्हणजे इंटरस्पेशालिटीमध्ये सुद्धा एवढ्या गोष्टी आहेत. तर त्याच्यामुळे आम्हाला ह्याच्यामध्ये गोल्डन आवरमध्ये ट्रीटमेंट आम्ही देऊ, पण पहिली गोष्ट मेडिकल लिगल कव्हरेज गरीब आहे, पैसे घ्यायचे नाहीत, डेथ झाल्यानंतर त्याच्याकडनं काही आधार कार्ड मागता येत नाही, मग मेडिकलचं रिएम्बर्समेंट करायचं कसं? तर त्यांचं असं म्हणणं आहे, बाळासाहेब ठाकरे रस्ते अपघात विमा योजना आहे, त्याच्या अंतर्गत तुम्हाला त्याचे पैसे रिएम्बर्स करता येतील. पण मी ज्यावेळेस माहिती काढली तर महाराष्ट्रात तुमच्याकडं कोणाला लाभ मिळाला असेल तर कोणी उठून सांगू शकता की असा जर काही लाभ मिळाला असेल तर मला कुठेही ऐकू येत नाही. मी ज्यावेळेस गव्हर्नमेंटला विचारलं की हे 2020मध्ये घोषणा झाली, 30,000पर्यंत होतं, 1 लाख झालेलं आहे, त्याच्यात बरेचसे आजार आहेत, पण एमर्जन्सी ट्रीटमेंट दिल्यानंतर हे रिएम्बर्स करायसाठी मागायचं कोणाला? मी माझ्या सोलापूर जिल्ह्याच्या सिव्हिल सर्जनला गेल्या आठवड्यात विचारलं 27 तारखेला, आणि त्यांना मी सांगितलं हा विषय मी आता आरोग्यमंत्र्याकडे घेऊन जाणार आहे. तर त्यांनी म्हणले नाही आहे तशी योजना, आणि बॅकडेटेड 24 तारखेचं पत्र माझ्याकडे पाठवलं. डॉक्टर आपण सोलापूर जिल्ह्यातल्या सगळ्या डॉक्टरांना आपण हे योजनेबद्दल कळवलेलं आहे. तर कुठेही माझ्या ऐकवत नाही, कराडमधल्या पण डॉक्टरांना कोणाला मिळाले नसतील. तर त्याच्यामुळे रिएम्बर्समेंट करायची जी काही ह्याच्यामध्ये तरतूद नाही ती करा. दुसरी गोष्ट आहे की स्टेट ऑथॉरिटी काउन्सिल, त्याच्यातला महत्त्वाचा विषय, महाराष्ट्र क्लिनिकल इस्टॅब्लिशमेंट ॲक्टमध्ये स्टेट ऑथॉरिटी काउन्सिल, डिस्ट्रिक्ट ऑथॉरिटी काउन्सिल, डिस्ट्रिक्टमध्ये ठीक आहे सिव्हिल सर्जन DHO असतात, आणखीन एक काउन्सिल काढतील, पण ते प्रत्येक इन्स्पेक्शन करायला येतील. ऑलरेडी तुम्ही एवढं सगळं इन्स्पेक्शन करता, सगळे कागदपत्र ऑनलाईन ऑफलाईन घेता, सगळ्या वरच्या सगळ्या गोष्टी देऊनसुद्धा आपण रजिस्ट्रेशन करून घेतो, आणि परत हे इन्स्पेक्शन म्हणजे इन्स्पेक्टर राज आहे ह्याच्यासाठी सुद्धा आपण विरोध करतो आहे. आणि दुसरं जे स्टेटचं ऑथॉरिटी काउन्सिल आहे, त्या ऑथॉरिटी काउन्सिलमध्ये आपण IMAचा मेंबर तर घ्याच, पण त्याच्यामध्ये NGOज पण घेत आहेत, पेशंटचे नातेवाईक पण घेत आहेत. तर ते खूप जास्ती म्हणजे घेण्याबद्दल काही नाही, परंतु त्या काउन्सिलला आमचं म्हणणं आहे की जे स्टेटचं ऑथॉरिटी काउन्सिल आहे तिथं तुम्ही घ्या. काही हॉस्पिटलची नोंदणी किंवा रजिस्ट्रेशन झालं नसेल किंवा त्याच्याकडे काही क्वालिफिकेशन नसेल, अशा हॉस्पिटलला तुम्हाला जे प्रशासकीय कारवाई करायचे अधिकार आहेत ते तुम्ही स्टेट ऑथॉरिटीकडे ठेवा. पण उद्या जर MMCचं काम जर हे जर स्टेट ऑथॉरिटी काउन्सिल करायला लागले आरोग्यमंत्र्याच्या अध्यक्षतेखाली, उद्या हॉस्पिटल कराडमधल्या समजा एखादी गोष्ट एखाद्या पेशंटनी तक्रार केली आणि त्याचं जर हे स्टेट ऑथॉरिटी काउन्सिल जर म्हणायला लागली की ह्यांचा निग्लिजन्स झाला, तर तो अधिकार MMCचा आहे. तर आमचं तेच म्हणणं आहे की तुम्ही फक्त नोंदणी, नियमन याच्या संदर्भात बोला किंवा पेनाल्टी, समजा एखाद्याने रजिस्ट्रेशन केलं नाही तर. दुसरा विषय आमचा तेच म्हणणं आहे की ह्याच्यामध्ये तुम्ही जर रजिस्ट्रेशन केलं नाही, रिन्युअल केलं नाही, शक्यतो तर एवढं आपले कधी करत नाहीत डॉक्टर्स, पण समजा एखादा असेल तर त्याच्यामध्ये पेनाल्टी 5 लाखापर्यंत आहे, 6 महिन्याचा दंड आहे, 6 महिन्याचा कारावास आहे. मग आम्ही त्यांना तेच सांगतो आहे की हे जे आहे म्हणजे क्रिमिनल फौजदारी केस दाखल करणं. आमचं म्हणणं आहे की 2000चा GR आहे बोगस डॉक्टरांचं. बोगस डॉक्टर शिक्षण नसताना सगळे ॲलोपॅथी डॉक्टर ड्रग्स वापरून जर पेशंट ट्रीट करतायत, तिथं डेथ झालं तर त्याला काही नाही आहे, आणि GRमध्ये त्याच्यामध्ये हार्डली 3 वर्षाची शिक्षा आहे, आणि आत्तापर्यंत महाराष्ट्रात कुठल्याही बोगस डॉक्टरला शिक्षा झाली आहे असं कुठं पेपरमध्ये ऐकण्यात नाही. आणि कुठं तर रजिस्ट्रेशन, रिन्युअल ह्याच्यासाठी 5 लाखापर्यंत दंड, 6 महिने कारावास अशी तरतूद आपण ती शिथिल करण्यासंदर्भात बोलतो आहे. किंवा जे जुने हॉस्पिटल्स आहेत, आता ते इन्फ्रास्ट्रक्चर बदलू शकत नाही, त्यांच्या आजूबाजूला ॲम्ब्युलन्स फिरावी, OPD एवढ्या पद्धतीत पाहिजे, हे त्या गोष्टीच्या संदर्भात सुद्धा आपण आरोग्यमंत्र्यासोबत चर्चा करतो आहे. हे सगळं जे काही बिल आहे याच्या संदर्भात जरी काही गोष्टी असल्या तरी ते बिल पब्लिक डोमेनमध्ये आल्यानंतर सर्वांना विनंती आहे, इवन प्रत्येक IMA मेंबर्स, सर्व स्पेशालिटीचे डॉक्टर्स, सगळ्यांनी त्याच्यामध्ये तुम्हाला जे जे वाटतं ते ऑब्जेक्शन तुम्ही ऑनलाईन सबमिट करा. कारण शेवटी हे बिल आहे ते आता येणार तर आहे, फक्त ते कशा पद्धतीने आपल्याला डॉक्टर फ्रेंडली करता येईल आणि कशा पद्धतीने आपल्याला त्या गोष्टीतून आपल्याला त्रास कमी होईल त्या गोष्टीसाठी आपण नक्कीच प्रयत्न करू. आपल्या सर्वांचं नेहमीच सहकार्य असतं. आणि परत एकदा मी कराड IMAचे अभिनंदन करतो आणि खास करून महाराष्ट्र राज्याचे AMSचे चेअरमन डॉक्टर रमेश भराटे, आजचे ऑर्गनायझिंग चेअरमन डॉक्टर वैभव चव्हाण सर, IMAचे सेक्रेटरी डॉक्टर राहुल फासे, ट्रेझरर डॉक्टर सविता देवकर मॅडम आणि अध्यक्ष दिनेश सर आणि संपूर्ण ऑर्गनायझिंग टीम, डॉक्टर अनिल देसाई सर आमच्या ऑर्गन डोनेशनचे को चेअरमन आहेत. पास पेशंट म्हणून गेल्या वर्षीसुद्धा मी अनिल देसाई सर असताना, राजगुरू मॅडम असताना या ठिकाणी इन्स्टॉलेशनला आलो होतो. आणि जसं भराटे सरांनी सांगितलं की वॉटर पोअरिंग वगैरे, तर खरंच हे खूप चांगली संकल्पना आहे. आणि आम्ही आत्ताच आमच्या महाराष्ट्र राज्याच्या एन्व्हायरमेंटल हेल्थ कमिटीच्या माध्यमातून इको फ्रेंडली ब्रँच, इको फ्रेंडली हॉस्पिटल ही कॉम्पिटिशन ठेवलेली होती. इको फ्रेंडली ब्रँचचा आत्ताच पुरस्कार आम्ही जाहीर केलेले आहेत. माझी आपल्याला विनंती आहे की इतर पुढच्या देखील एन्व्हायरमेंटल हेल्थ कमिटीच्या ॲक्टिव्हिटीमध्ये आणि इतरही सर्व ॲक्टिव्हिटीमध्ये कल्चरलची आमची वुमन्स विंगची कॉन्फरन्स, सर्व वुमन्स विंगच्या मेंबरला मी विनंती करतो की 3 आणि 4 ऑक्टोबर अहिल्यानगरला आहे, आपणही त्या कॉन्फरन्समध्ये सहभागी व्हा. स्पोर्ट्सची कॉन्फरन्स जी आहे ती 29, 30, 31 ऑक्टोबरमध्ये अकोल्याला आहे. आपल्याकडचे भरपूर स्पोर्ट्सचे सगळे मेंबर्स आहेत. गेल्या वर्षी मी बऱ्याचशा स्पोर्ट्सच्या इथल्या मेंबर्स लोकांनासुद्धा मी अवॉर्ड्स दिलेलं होतं. खूप व्हायब्रंट ब्रँच आहे. आणि सगळ्यात महत्त्वाचं आणि शेवटचं मी वैभव चव्हाण सरांना सांगतो की आपला महाराष्ट्र राज्याचा जो लीडरशिप डेव्हलपमेंट प्रोग्राम आहे, त्या प्रोग्रामच्या अंतर्गत AMSची राज्याची ॲक्टिव्हिटी म्हणून संपूर्ण महाराष्ट्रासाठी जी कराड ब्रँच एक आदर्श म्हणून आहे, ते म्हणजे MPCBचा प्रकल्प. आज आम्ही सांगतो की तमिळनाडूमध्ये, केरळमध्ये हा प्रकल्प आहे आणि आपल्या महाराष्ट्रामध्ये कराडच्या माध्यमातून कारण असा प्रकल्प IMA चालवते. तर ह्याची कुठंतरी महाराष्ट्र राज्यातल्या सर्व प्रेसिडेंट सेक्रेटरीला, IMA मेंबरला आणि याचं काहीतरी अनुकरण बाकीच्या महाराष्ट्रातल्या ब्रँचेसनी करावं. याच्यासाठी मी वैभव चव्हाणांना विनंती करतो की आमच्या लीडरशिप डेव्हलपमेंट प्रोग्राममध्ये AMSची ॲक्टिव्हिटी म्हणून तुम्ही कराडचे जे काही तुमचे पदाधिकारी ह्या MPCB प्रकल्पाचं काम करतात, त्यांनी प्रकल्प कसा करावा, त्याच्यात येणाऱ्या अडचणी, त्याचं रजिस्ट्रेशन कसं करावं आणि कशा पद्धतीने ते तुमचं फिजिबल आहे, हे सर्व डिटेल्स त्यांचा जो प्रोजेक्ट आहे त्यांनी तर मला पाठवलेला आहे. परत एकदा शॉर्टमध्ये जर पाठवला तर सगळ्या ब्रँचेसला पाठवू आणि तुम्ही सर्व महाराष्ट्रातल्या लोकांना माहिती द्यावी अशी माझी विनंती करतो. आणि आजच्या कार्यक्रमाला आपण बोलवलं, आपल्यासोबत संवाद साधण्याची संधी मिळाली, त्याबद्दल मी सर्व संयोजकाचे आभार मानतो. जय हिंद, जय महाराष्ट्र, जय सद्गुरू.
Thank you, sir. Now I request Dr. Fase sir to kindly poster presentation. Are the presenters of the posters all present here? Yes, okay, fine. So we will conduct the poster presentation award ceremony. First, I would like to invite Dr. Ajay Brahmanalkar sir, Dr. Manoj Joshi sir and Dr. Sunil Lawan sir to come on stage to be felicitated as they were the judges for this competition. I request Dr. Santosh Kulkarni sir to kindly felicitate them. Take a round of applause. Dr. Manoj Joshi sir. Dr. Sunil Lavan sir. Okay, fine. Now we'll declare the winners. I request both Dr. Santosh Kulkarni sir and Dr. Ramesh Bharate sir to kindly give away the awards. For the medicine posters, the third prize goes to Dr. Rushil Patel. He has given a case report on mixed connective tissue disorder presenting with pleural effusion.
The next prize goes to Dr. Arushi Tibriwal for Beyond the Sinuses, the lethal spread of mucormycosis, rhino-oculocerebral mucormycosis with meningoencephalitis. The first prize goes to Dr. Yogesh Jagtap for Beyond Dysphagia, bulbar onset generalized myasthenia gravis with thymoma presenting as myasthenic crisis. Dr. Yogesh Jagtap. Okay, can somebody take his prize? Please hurry. The prize in the pediatric section goes to Dr. Kirti Palaparthi. She has given a case presentation on Steven Johnson syndrome, toxic epidermal necrolysis. Dr. Kirti Palaparthi. Thank you, Dr. Santosh Kulkarni sir and Dr. Bharate sir. And congratulations to all the winners. Now I request Dr. Fase sir to kindly give us his vote of thanks.
Thank you, ma'am. Before going to vote of thanks, our MOC team has done excellent job since morning. So I request our chief guest, Dr. Santosh Kulkarni sir and Dr. Ramesh Bharate sir to felicitate our MOC team. First of all, I request Dr. Shailaja Kulkarni. Please, ma'am. Dr. Mamta Kale, ma'am. Dr. Shweta Dhage. And also, last but not the least, our sponsors who have done excellent job in organizing this wonderful conference. If at all they are here, I request them to come and take their felicitations also. Someone from Karad Hospital, our chairman, Dr. Anil Desai sir, I request Dr. Desai sir on behalf of Karad Hospital has sponsored this conference. Sahyadri Hospital, Dr. Chinmay Eram, if at all is here. Yes, please. Sahyadri Hospital also has supported us in this wonderful conference. Apollo Hospital, Mumbai, I think they have not here. Juventus Pharma, someone from Juventus Pharma. Polymed Pharma, Schiller's company. These are Schiller's. I think they are busy with the stalls. We'll get them. Also, Dr. Mamta Kale, madam, she has also sponsored one session.
Dr. Sanjay Pawar sir, Shri Ratna Hospital. Dr. Vijay Singh Patil, Sanjeevan Hospital. Dr. Mahendra Patil, Shalini Lab. And our organizing chairman himself, Dr. Vaibhav Chavan sir. I really thank from bottom of my heart for all these sponsors for supporting us in organizing this wonderful conference. Also, respected Chief Guest, Dr. Santosh Kulkarni sir, President AMS, Dr. Ramesh Bharate sir, Vice President AMS, Dr. Vaibhav Chavan sir, President IMA Kara, Dr. Dinesh Oswal sir, all our executive organizing team, distinguished speakers, honored delegates, faculty members, organizing committee, and dear participants. On behalf of organizing committee, it is my privilege to propose the vote of thanks to all of you. With the theme Empowering Doctors and Elevating Care, we extend our heartfelt gratitude to our esteemed speakers for sharing their valuable knowledge, clinical expertise, and inspiring insights in the field of medicine. Your contributions have made this conference both enlightening and enriching. We sincerely thank our chief guest and all the dignitaries for gracing this occasion with their presence and encouragement. Our special appreciation goes to organizing committee, scientific committee, moderators, volunteers, and technical support team led by Mr. Ram Extreme and his team, Extreme Lights, with his team. Also our photographer, Mr. Deepak Thorat, Beats Hotel Management and all their team, and of course, not least but not the least, all the delegates and all the members and team of my IMA team. We are also grateful to all our sponsors who we have just felicitated. All the partners who have supported us. A heartfelt thank to all the delegates and participants for your enthusiastic involvement. Your presence has truly made this gathering meaningful. As we conclude, let us carry forward the knowledge, ideas and collaborations gained here to continue improving patient care and advancing the field of medicine. Once again, thank one and all for all of you for your valuable time, support and contribution. Thank you. Jai IMA.
Thank you, Fase sir. Now I request all of you all to proceed for lunch and also visit all the stalls which are just besides the lunch area. The lunch will be served right in front of the gate of this hall. Also, I request all of you all to please come back for the post-lunch session so that there are more interesting topics. We have more interesting speakers. Thank you.